We are live now. Good evening, esteemed faculty members, speakers, delegates, and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by AMOGS Emergency Obstetrics Committee with Kurnool, Ongole, Bhimavaram, and Srikakulam OBGYN societies. And today's episode is number 10. And it's my privilege to introduce the MOC of today's webinar, Dr. Niharika ma'am. Ma'am is the past secretary of Visakhapatnam OBGYN Society, consultant obstetrician and gynecologist at Birthright by Rainbow Hospitals, Visakhapatnam, and also executive member of Vaginal Surgeries Committee, FOXY 24 to 25, cell member publication cell, FOXY 24 to 25. I welcome you, ma'am. And it's my privilege to introduce Dr. Sailaja Nalluri ma'am. Ma'am is the Civil Surgeon Specialist, Insurance, Medical Services, Vijayawada. Ma'am has been the past Treasurer and Secretary of Vijayawada OBSGYN Society. I welcome you, ma'am, and I hand over the session to Dr. Niharika, ma'am.
Thank you, Sahiti. A good evening and a warm welcome to all of you on behalf of AMOGS Obstetrics Emergency Committee. And this is a webinar, which is 10th webinar, which is being conducted today in association with Kurnool, Ongole, Bhimavaram, and Srikakulam societies. So we are thankful to Dr. Sneha Bhuyar for this opportunity for all these societies. And Sahiti, can we have the invocation, please? So let us start by taking the blessings from the Almighty.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं.
Thank you, Sahiti. So now it is my pleasure and privilege to introduce Dr. Sneha Bhuyar. She has been the chairperson for FOXY Breast Committee from 2019 to 21 and a governing council member of ICOG and National Adolescent Trainer, National Expert UNICEF, a peer reviewer of Jogi. She has many awards to her credit, and I think all of us know her for her extremely friendly demeanor and academic excellence. So welcome, Dr. Sneha Bhuyar, madam. And now I request Dr. Sneha Bhuyar, madam, to introduce the chief guests and guests of honor and take their blessings and proceed for the inaugural.
Yes, thank you so much, Niharika, for that wonderful introduction. A very good evening and warm welcome to all of you. This is Dr. Sneha Bhuyar, and of course, I'm the chairperson of AMOGS Emergency Obstetrics Committee. So, my regards and respects to all the seniors, respected Dr. C.N. Purandare sir, the mentor for so many, including me, Madam Shantakumari, who is busy somewhere, so maybe she'll join shortly. The chief guest for today's program, and of course, Dr. Madhuri Patel, Madam Suvarna Khadilkar as guest of honor. Our host team, of course, AMOGS President Dr. Kiran Kurtakoti, Dr. Bipin Pandit as Secretary of AMOGS, and Dr. Rajendra Singh Pardesi sir as immediate past President of AMOGS, and the entire team of AMOGS office bearers. I also welcome all the esteemed speakers for today's program, Dr. Aruna Kumari, who is the President of Rajahmundry Society. She'll be speaking on cesarean scar ectopic. Madam Sujata Darve will be speaking on the difficulties in cesarean section. So I welcome the chairpersons, especially Dr. N.K. Amla, Dr. G.K. Kalpana, all these from Ongole Society, the Narsavani, Dr. Lakshmi, Dr. Radha Lakshmi from Nadia, Dr. Parvati, and of course my expert and dear expert panelist and dear friend Dr. Vidya Tobe, who is the past president of Kasoga, Dr. Venkataramana, who is the president of Kurnool, and my learned panelist, of course, Dr. Sudharani, Dr. Rajya Lakshmi, Dr. A. Sridevi, Dr. Deepa, Dr. Nalini, Dr. Nirupama, Dr. Sandhya Rani, and Dr. Bhagya Priti, And of course, my very important friends, right and left hand from Andhra Pradesh, Dr. Niharika Allu and Dr. Sailaja Nalluri. I welcome all of you here for this program, and we have received the blessings of God, and we are eagerly waiting for the blessings of our respected seniors. So it's my pride and privilege to introduce respected Dr. C.N. Purandare, sir. As I have already said, sir is the mentor of so many, almost I would say we are the whole India, because we are so proud of you, sir, being the past president of FICO and past president of FOXY. Sir was the Dean of Indian College of Obsgyny and Emeritus Editor for the Journal of Obsgyny of India. And of course, sir has the Fellowship of Royal College of London and so many accolades. I think, sir, I'm a very small person to introduce you, but I would like to have your blessings and your inspirational words. So over to you for your words, sir, respected Sir Purandare. Sir, please unmute.
Okay, I managed to unmute myself. Thank you very much, Neha, for inviting me today for your CME. And I must say that it's a very apt topic to choose because of the high cesarean section rate that has caused all these problems subsequently, like scar ectopics to placenta accreta to all sorts of complications which are faced on a regular basis by obstetricians. Interestingly, when I went to Egypt, in Egypt, their Premier Institute has a separate department. As a matter of fact, a separate unit, which is on call 24 hours, which is called the accreta unit. And anytime anybody faces this problem at the time of cesarean section, this accreta unit is called in to resolve the crisis. Of course, with the modern imaging technology, we can know that there is an accreta and the risk of how deep the accreta is and so on, the vascularity. And institutions where possibility of embolization is available, even the catheters can be put in before the section begins. So in case embolization has to be done, it is done on the table itself. So there are so many advances that have taken place. But being aware of that is a very important aspect of obstetric practice. And average obstetrician thinks that with previous cesarean section, I'm doing it now the second time. It will sail through. It's not so simple as that. In many occasions, you are suddenly confronted with difficult problems. In one of the congresses in Beijing, where I was there during my FIGO presidency, and at that time China had changed from one child on to two children. And there was an audience of about 600, 700 people in front of me, and I asked them if how many of them had delivered a second baby. And literally none of them had delivered a second baby. And the section rate in Shanghai, China was over 60%. So those 60% women who would go ahead and plan their second baby, all these complications were expected. And when the obstetrician has never seen a second delivery, how are they going to manage problems which are associated with the second baby with previous LHCs, with majority of them landing with you with previous LHCs. So the whole need for change in attitude, learning about what it is and how to deal with it is extremely important. I'm happy that Neha, you have come forward with this topic so that the average obstetrician gynecologists everywhere who are watching this will know the problems which are and how to deal with them. And I'm sure all those ladies who are going to speak in the next 3 sessions will highlight all those aspects of it to help them deal with it. And it's nice to see Rajendra Pardeshi there, if not in person, at least on Zoom. And many of you whom I have met somewhere or the other. And I remember the time when I was contesting the FIGO Foxy's presidency, and I was going, and I went to 3 different cities in one day. There was in the south with Santa Kumari, went to the Rajamundry and 2 other places as well, which were nearby. One of them, which was a university, I forget the name now. But it was very interesting to visit all these smaller places. And I'm sure they have become over now in the last 15 years. They have become huge organizations, those who are only 100 member societies. I'm sure they are crossed 1,000 at this stage when we are talking about the overall membership of Foxy reaching 50,000. So anyway, all the very best to all of you for the CME and especially Sneha for taking this initiative and taking it forward. All the best to you.
Thank you, sir. I just utilized this opportunity to have not mentioned initially. I'm contesting for Foxy Vice President from West Zone, and sir, I seek your blessings.
My blessings are always with you.
Thank you, sir. Thank you so much. I'm very happy that you have witnessed the journey from a smaller common member, Foxy member, reaching to this level. So I'm very happy the way you have handhold and taught us, how to walk further. Thank you so much, sir. Thank you so much once again. So with this, I introduce Dr. Rajendra Singh Pardesi, the immediate past president of AMOGS, and of course, our advisor, committee advisor, and open mentor to me in person. So we would like to listen to your precious words, sir, Dr. Rajendra Singh Pardesi.
Good evening, everybody. Respected Chief Guest, Dr. Purandre sir, Dr. Shanta Kumare ma'am, and both are stalwarts of FIGO. I am feeling proud and honored to be a part of this program where Dr. Purandre sir is there. Guest of honors, Dr. Madhuri Patel, Dr. Suvarna Khadilkar, and our AMOGS President, Dr. Kiran Kurtakoti. So I wish to congratulate Dr. Sneha for organizing this webinar with Kurnool, Bhimavaram, Srikulam societies. See, AMOGS is now extended its hands and they are joining with hands in any other societies in India also. I met Dr. Venkat Ramana from Kurnool. I think he is here only. And they were fighting for the conferences. And then I know the problems of the societies also. And they were they were to organize in Tirupati and all that. So all these AP societies, we assure that our AMOGS is with you only, all AP societies in next meeting. Dr. Ramanna sir.
Sir, thank you, sir.
Thank you, sir. Myself,
we will be with
Dr.
you.
Radhalakshmi, Secretary, Kurnool.
Yes, you are thank me. So
Thank
we
you,
will
sir.
Good evening,
support.
sir. I'm Dr. Venkatramanna.
Yeah, Venkatramanna has also joined.
See,
Yes, sir.
we
Thank you,
felt
sir.
very
Thank you,
bad
sir.
at that time. We felt very
Sir, sir.
bad due to some technical that has been
Yes, sir.
rejected. That is not the problem.
Yes, sir. Sir,
So
sir.
we told also, and we will support you wholeheartedly next time.
Thank you, sir.
So topic chosen, they are of very much importance of day-to-day practice, and they will help in reduce MMR with the eminent faculties, chairpersons, panelists, and all. I think this is going to be a great event. I think Dr. Vidya is also there. I wish every success to Dr. Sneha Bhoyar and my friend Dr. Vidya Thobi in their future endeavor in Foxy as Vice President Foxy. Dr. Sneha Bhoyar is also our active, ever smiling and ever active chairperson of AMOG, and Vidya was president of Kasoga. She is very active. So we appeal to vote for them. wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much. Now, do we have Madam Madhuri Patel joined, Dr. Niharika?
No, ma'am, I don't think so.
So I think both the guest of honors, yeah.
Join little late, so
Okay.
she will join little late.
So I just thank all the dignitaries, and I think Dr. Kiran also has not joined. So especially I thank respected Dr. C.N. Purandare sir for sparing time for our webinar, and from his busy schedule, of course, and his words of wisdom and guidance definitely will help all of us. I'm sure the audience has, actually benefited from what the sir has talked about the previous season section and all the difficulties. I think the summary of this webinar, sir, has already given you as a message. So thank you so much, sir, once again for being here and guiding us. Thank you, respected Dr. Rajendra Singh Pardeshi, sir, for your precious words and of course your support and guidance always. I thank all the faculties joining this webinar and all the attendees. And without much ado, we would like to go ahead with the academic session. So over to you, Dr. Niharika. Once the guest of honor join, we can have their words. Thank you so much, all of you once again. Thank you, sir. Thank you so much.
Thank you, Dr. Sneha. So that was a wonderful inaugural for us. And let us proceed with the scientific session for today. So the first topic for today's scientific program is on cesarean scar ectopic. And I would like to introduce the chairpersons for this session. So Dr. Kamala Manduva, she's done her MBBS from KMC Hubli and DGO from AIMS Bellore. And she's an infertility specialist and a laparoscopic surgeon and a motivational speaker. Welcome, madam. Next. Next, we have Dr. Kalpana. She's done her MBBS from Guntur and DGO from Rangaraya Medical College. And she is FAM, Fellow of Minimal Access Surgery and a consultant at KIMS Ongole. Welcome, madam. We have Dr. Radha Lakshmi. She is a professor at Shantiram Medical College, Nandyal, and also the Secretary of Kurnool Obstetrics and Gynec Society. Welcome, Dr. Radha Lakshmi. Now, I request the chairpersons to introduce the first speaker for today, Dr. Aruna Kumari. Do we have Dr. Kamala or Dr. Radha? You can introduce the speaker.
So, Dr. Aruna Madam is graduate from Rangaraya Medical College. She is university first in final year MBBS and she did her post-graduation from PGI Chandigarh. She is the ex-associate professor, GSL Medical College, Rajahmundry, senior obstetric consultant, and her areas of interest are infertility and high-risk pregnancy. Started MBBS Rajahmundry OBG Society and conducted many CMEs and Andhra Pradesh State Conference 2012 and 2021. So I welcome you, madam, to deliver your lecture and give your important points for us.
Thank you, Radha madam, for your kind introduction. Thank you, Madam Sneha madam, for giving this opportunity for us to interact with all of seniors and my colleagues. And I wish you all the best, madam, in your...
Sneha madam, good evening. And other seniors and junior colleagues.
Thank you,
My
Radha
pleasure to have all of you, Dr. Radha Lakshmi and Dr. Aruna Kumari. Please go ahead with the talk. Thank you so much.
Thank you, madam. Today, first I want to share my screen.
Yes, Sahiti, I hope you have made Madam co-host.
Ma'am, all the panelists can have access, ma'am. Yes.
Okay, please go ahead with sharing.
Aruna ma'am, please click on share screen option, ma'am, which is in green color.
Yeah, I'm trying to share my screen, but I think it's not working. I don't know why.
After clicking that, there is one other option called share. If you click on the share, it will be shared, ma'am.
Okay.
Yes.
Yes,
Yeah.
ma'am. We can see your desktop, ma'am, but
Yeah,
please.
I'm starting my presentation. 1
Yes,
minute.
ma'am. Thank you. We can see your slides, ma'am.
Okay.
Yes,
So
ma'am. Thank you, ma'am.
thank you. Thank you, Sneha madam, for giving you this opportunity, and all the best, madam. First, good evening, all seniors, Dr. Purandare sir, Dr. Rajendra sir, and Dr. Madam Vidya madam, and all my colleagues and friends. Today, my topic for discussion is cesarean scar ectopic. As we all know, cesarean scar ectopic is an abnormal implantation of the gestation sac in the fibrous tissue of the previous cesarean scar. It's increasing in incidence and it's a life-threatening condition. If it left untreated, majority of these cases will progress into placenta accreta spectrum, which as already mentioned by our Dr. Purandare sir, with its associated dreaded complications like uterine rupture, massive hemorrhage, and sometimes the need for gravid hysterectomy, and sometimes a maternal mortality also. So early recognition of these cesarean scar ectopic pregnancies and timely management is very essential to optimize the treatment and improve patient outcomes. So today I'm going to discuss this topic under the headings of what is the definition, its prevalence, what are the risk factors which will increase the incidence of cesarean scar pregnancy, what is its natural history, how to diagnose, and what are the various treatment options available. Coming to definition, is the embryo implants on or in the fibrous tissue of the previous cesarean hysterotomy scar. If unrecognized or inadequately managed, it may lead to severe maternal morbidity and mortality like severe massive hemorrhage, uterine rupture, placenta accreta spectrum of disorders with their associated complications. Sometimes, rarely, maternal mortality also. One thing, it's a peculiar type of ectopic pregnancy in that the baby, the gestational sac, grows into the uterine cavity. Although it's implanted in this scar, it grows into the uterine cavity, and if it left untreated, can result in viable pregnancy in majority of these cases. So what is its prevalence? The true incidence is unknown. The incidence ranges widely from 1 in 1800 to 1 in 2500 in various published literatures. The incidence is about 0.15% in women with previous cesarean sections. If we consider only those women with previous cesarean sections, it is 0.015%. And it accounts for 6% of all ectopic pregnancies in women with at least one previous cesarean section. So nowadays, recently, the incidence of cesarean scar ectopic pregnancy is increasing in incidence. The reasons may be first, there's increasing incidence of cesarean deliveries and other intrauterine procedures which may damage endometrium may also increase the incidence of cesarean scar ectopic pregnancy. The other reason may be the increasing availability of the diagnostic modalities like transvaginal ultrasound with color Doppler and MRI, which may help us in diagnosing cesarean scar pregnancy with high precision. The third and very important reason for the increasing incidence may be increasing physician awareness. Our mind know, only our eye will start saying. When the awareness of cesarean scar pregnancy is increasing, maybe the incidence is also increasing. Coming to pathogenesis, the presence of cesarean scar defect with defective desexualization is the main underlying factor for the occurrence of cesarean scar pregnancy. The endogenous migration of the embryo through the microscopic defect within the scar will lead to implantation in the fibrous tissue or in the myometrium. The hypoxic environment in this fibrous tissue will lead to invasion and proliferation of the placental villi in the myometrial wall. And this placenta get attached directly into or through the myometrium, leading to adherent placenta. The fibrous nature of the scar tissue and inherently deficient implantation site are at high risk for dehiscency, thus uterine rupture during pregnancy. So as we already seen that the main underlying factor for cesarean scar pregnancy is cesarean scar niche or defect formation. What are the factors which may predispose to this formation of cesarean niche are? First one, multiple cesarean sections. More than 2 cesarean sections are associated with increased scar area and maybe increased chances for defect formation. But recently, many studies showed that even a single cesarean section is associated with increased chances of cesarean scar ectopic pregnancy. The other factors which may predispose us to increased chance of niche formation are the elective procedures performed on unformed lower uterine segment, which may lead to poor healing of the cesarean scar, or the sections which are performed during second stage, which may lead to cesarean incision done on the cervical tissue, may lead to poor healing of the scar, leading to cesarean defect formation, scar defect formation, and the changes in the surgical technique, which is very important, which we can improve. Nowadays, many studies showed that the single layer closure is associated with defect formation when compared to double layer closure. And the technique of the cesarean section closure, that is the interlocking sutures are associated with more chances of fibrous tissue formation and defect formation. So at least in primary gravidas, we should again revert back to double layer closure with decreased use of interlocking sutures. And poor wound healing occur whenever there is a postpartum anemia, postpartum sepsis, or whenever the maternal condition is not good, like patients with diabetes, other maternal diseases like connective tissue disorders. There will be poor wound healing, leading to increased chances for cesarean defect formation. So we should try to decrease all these conditions and avoid this cesarean scar defect formation to decrease the incidence of cesarean scar ectopic. What are the other risk factors? History of previous cesarean scar pregnancy. The risk of recurrent cesarean scar pregnancy may be 5 to 40% according to various studies. Any previous uterine surgery that could potentially damage the endometrium, like multiple induced abortions after a cesarean section, multiple DNCs, endometrial ablation, and all other these procedures can also enhance the formation of cesarean scar ectopic. So coming to natural history of the disease, that is, if we left untreated these ectopic cesarean scar pregnancies, what will happen? If these patients are diagnosed with a viable pregnancy at the time of diagnosis, 13% of them will have an uncomplicated miscarriage. But at least around 10% of them will have a uterine rupture during first and second trimester of pregnancy itself, and 15% of them may need gravid hysterectomy. And if these pregnancies are left untreated, around majority of them, around 2/3 of them will progress to third trimester of pregnancy. And among these patients, around 77% will have placenta accreta spectrum diseases, and 2/3 of these are placenta percreta with its associated complications like massive hemorrhage and requirement for massive transfusions, and sometimes maternal mortality also. And if we have a non-viable cesarean scar pregnancy at the time of diagnosis, 70% of them will end up in an uncomplicated miscarriage. That means 30% of these non-viable cesarean scar pregnancies will also need surgical or medical intervention in the form of either medical management or surgical management. And in these non-viable pregnancies also, 13% will have uterine rupture because of formation of abnormal AV malformations, and hysterectomy is not required. But according to many studies, in these non-viable pregnancies, hysterectomy may not be required. Coming to diagnosis. First, clinical presentation. Majority, more than 1/3 of them are asymptomatic, and these are usually diagnosed during routine transvaginal scan. And 1/3 of them may present with hemorrhage or pain, and sometimes, rarely, these cesarean scar pregnancies may also present with ruptured cesarean scar pregnancy with hemodynamic collapse. The first line investigation to diagnose cesarean scar pregnancy is transvaginal ultrasound with color Doppler, added with transabdominal ultrasound with full bladder. The transvaginal 3D ultrasound power Doppler rarely contributes. MRI may have a role when there is a doubt of diagnosis, and the MRI may provide useful information regarding the degree of invasion and the evidence of placenta accreta spectrum of diseases. In laparoscopy, the caesarean scar ectopic can be diagnosed as an ecchymotic bulge with a salmon red appearance beneath the bladder at the level of previous caesarean scar. These are the various ultrasound pictures to diagnose caesarean scar pregnancy. This is the caesarean scar pregnancy present at the lower uterine segment in the anterior wall near the previous caesarean section scar. And there will be empty uterine cavity and empty cervix, empty and closed cervix. And there will be a deficient myometrium at the site of the gestation sac, and there will be thinning of the myometrium anteriorly, and the myometrium will be thinned between the bladder wall and the gestational sac. The other features of caesarean scar ectopic may be the bulging of the gestational sac into the bladder, and there will be irregularity of the bladder wall and the loss of myometrium between the gestational sac and the bladder wall, and there may be increased vascularity around the gestation sac at the implantation site, that is between the bladder and the previous caesarean scar. The vascularity will be trophoblastic type of vascularity, like there is very high velocity and low impedance flow. And if you have any doubt of diagnosing caesarean scar ectopic, as after 7 weeks, what will happen? This pregnancy will start growing into the uterine cavity. First, at up to 7 weeks, it's very easy to diagnose the caesarean scar ectopic, which is present at the scar. As the pregnancy advances, the fetus start growing into the endometrial cavity. And it's very, at the time when after 9 weeks, it may be there may be some confusion in diagnosing the caesarean scar ectopic. In those cases, we can come to a conclusion with the help of when we draw a longitudinal line from the fundus of the uterus to the cervix, and if this longitudinal line is divided into two halves, that is, uterus is divided into two halves with an imaginary line drawn perpendicular to the longitudinal axis, and we will mark the center of the gestational sac. If the center of the gestational sac above this perpendicular line, then it is an intrauterine pregnancy. If the center mark of the gestational sac is below the perpendicular line, then it is an caesarean scar ectopic. When we have a doubt, we can draw this diagram to diagnose whether it is an intrauterine pregnancy or a scar ectopic. So, to summarize, a low anteriorly located gestation sac should raise concern for a possible caesarean scar ectopic and warrants further investigation to confirm the diagnosis. The diagnostic criteria for caesarean scar ectopic are empty uterine cavity and closed and empty cervical canal, low anterior position of the gestation sac before 7 weeks, a triangular, round or oval shaped gestation sac that fills the niche of the scar, a thin or absent myometrial layer between the gestation sac and the bladder, the placental circulation characterized by high velocity and low impedance blood flow in the area of caesarean scar. Negative sliding organ sign may help us to differentiate the caesarean scar ectopic from the inevitable abortion, that is failing intrauterine pregnancy, which is present at the lower uterine segment. When we apply pressure on the cervix with a transvaginal probe and we'll give a pressure, the failing intrauterine pregnancy will move. We will have a to and fro movements, but the caesarean scar pregnancy doesn't move. There is a negative, that is a sliding organ sign. So, if the diagnosis is not certain at the first scan, a second opinion scan or an additional imaging with MRI should be considered to establish a timely diagnosis without undue delay. So whenever there is a doubt in diagnosis, we should take a consultant opinion or senior opinion or further investigation, and we should confirm the diagnosis at the time itself. We should not postpone the diagnosis for the next visit. Coming to differential diagnosis, cervical ectopic pregnancy, in which there will be a bulging of the cervix and opening of the cervix, and the implantation will be seen in the cervical canal. A spontaneous abortion in transit, as we've already discussed, the sliding organs slide. This sliding organs sign will help us in differentiating cesarean scar ectopic from the inevitable abortion, and the fetal heart will be absent, and there won't be any peritrophoblastic blood flow in these pregnancies. So once we confirm the diagnosis, many others devised many classifications and grading systems for this cesarean scar pregnancy to develop management strategies and to give prognosis of these pregnancies so that we can manage them in an efficient manner. There are so many classification systems, but the most commonly used classification system is devised by Weil et al. According to this classification system, the cesarean scar pregnancy is divided into type 1 and type 2. The type 1 pregnancy is on-scar pregnancy, that is, this cesarean scar, this pregnancy is implanted on well-healed scar of a previous cesarean birth. This is also called as endogenous implantation. In this type of pregnancy, the gestation sac grows into the uterine cavity, and usually these patients will have a favorable prognosis with a chance for viable birth. But mind you, these patients also, around 2/3 of them will have placenta accreta spectrum of disorders with its associated complications like hemorrhage and rupture. The type 2 is in the niche type of pregnancy. In these cases, the implantation occurs within the defect or in the niche of an incompletely healed scar. This is also called as niche pregnancy or exogenous implantation. In this, the pregnancy gestational sac grows outwards towards the bladder, and this is a more dangerous type of dangerous and life-threatening condition where it leads to uterine rupture and hemorrhage in the first trimester itself. So now coming to management of this dreaded condition. The optimal treatment is not known. There's so many type of modalities available, and many times a various combination of such treatments are tried. The main aim of the treatment is to conserve the uterus and the maintenance of the health and quality of the life of the woman. The various modalities available are expectant management, medical management, either systemic methotrexate or local intragestational methotrexate or other drugs. Surgical management, it can be a less invasive procedure like ultrasound guided suction aspiration or operative wedge resection, either with the help of laparoscopy or through laparotomy or transvaginal route or a combined histolaparoscopic route or gravid hysterectomy. The
Aruna,
other
madam, you are not audible.
Not audible.
Hello.
Yeah. Is it okay? Am I
Aruna,
audible
madam.
now?
It is okay. It is okay. No worries. Go ahead.
Okay, ma'am.
Not
Thank
audible,
you.
madam. Not audible.
Madam Sneha, madam, am I audible?
It's perfect. I think, madam, you are audible. Absolutely no problem. I think that must be somebody's personal problem about internet or the device. You are well audible. No problem. Go ahead, please.
Thank you so much, ma'am. The other managements are adjuvant treatments like balloon occlusion, balloon catheter occlusion, or uterine-artery embolization, which we'll discuss in detail later on. But in majority of cases and majority of studies, various combination of such treatments are tried. Not the single treatment is not tried, but usually this combination of such treatments are tried. And one more caution is all the cesarean scar pregnancies are high-risk pregnancies and should be managed at a tertiary care hospital where a variety of treatment options are available and a blood bank services where the massive transfusion is required is available. Coming to various types of management, first one is the expectant management. All guidelines recommend against expectant management for cesarean scar pregnancy, even in non-viable pregnancy. Why? Because it takes several months for a non-viable cesarean scar pregnancy to resolve completely. So the patient should be under follow-up till the pregnancy resolves completely. And sometimes in around 10 to 20% of cases of these non-viable pregnancies may develop acquired uterine arteriovenous malformations AVM with its associated persistent severe vaginal bleeding, which may require further treatment either with uterine artery embolization or with hysterectomy. But this cesarean expectant management can be tried in cases of failed pregnancy, that is a fetal death with an evidence of early pregnancy failure, where there is a decreasing beta HCG levels, and this beta HCG level should be less than 2000. The management protocol is weekly follow-up with serum beta HCG until the HCG become undetectable, and bi-monthly follow-up with transvaginal ultrasound till the pregnancy recedes completely. And during this period, the mother should be monitored carefully for the development of any new symptoms like hemorrhage or lower abdominal pain, which may indicate development of these acquired AVMs and uterine rupture. And around 10 to 20% of these patients which are under expectant management for non-viable pregnancy may require further treatment either in the form of systemic methotrexate or suction aspiration when there is persistently elevated beta HCG levels, or to hasten the resolution of this demised pregnancy where the patient cannot come for further follow-ups. The expectant management for a live pregnancy. Again, all guidelines recommend against expectant management of this live cesarean section pregnancy. And if this woman refuses for termination, these patients should be counseled about the risk of significant obstetrical complications associated with expectant management of this cesarean scar pregnancy, like progression into placenta accreta spectrum of disorders. The uterine rupture can occur at any time during pregnancy, that is at either first trimester, sometimes in second trimester also, and the associated massive hemorrhage and requirement for the hysterectomy. All these patients should be counseled thoroughly regarding these complications. In spite, if she wants to continue, then we can manage expectantly. The better prognosis is expected in those patients with the endogenous implantation, and when there is myometrial thickness between the gestational sac and the bladder is more than 3 mm. And all these patients should be managed in a high-risk obstetric units where these patients should be counseled regarding the signs and symptoms of uterine rupture. That is, the development of a persistent lower abdominal pain or occurrence of bleeding, or on scan there is a thinning of the myometrium. All this will alert us towards the development of uterine rupture. And development of preterm labor also should be advised to the patient. And if she continued progress till term without any complications, then all these patients should have an elective cesarean section at 34 to 35 weeks gestation in level 3 or 4 facilities with appropriate expertise and resources and capability for massive transfusion. And all the team should be prepared for the potential need for cesarean hysterectomy and massive transfusion. So coming to medical management, the medical management is less expensive, associated with less complications, and needs less expertise, and all our gynecologists can do this medical treatment. The main disadvantage of medical treatment is it needs long follow-up. With the medical management, the gestational tissue and beta HCG will take long time, from 4 weeks to 4 months to have complete resolution. Till then, the patient should be followed up. So whenever a patient is subjected to a medical management, these patients should be counseled regarding the long-term follow-up and the requirement for the surgical intervention whenever it is necessary, and the other associated complications. These patients should also be counseled regarding the other associated complications like development of AVM and development of sudden hemorrhage, which may require surgical intervention. Coming to medical management, these two types, one is systemic and other is local. The systemic methotrexate is not effective as a single standalone treatment because this gestational sac is in a fibrous scar tissue with least vasculature. So the systemic methotrexate may not reach in adequate concentrations to be effective to cure this cesarean scar ectopic. The success rate with the systemic methotrexate alone is only around 50%, And the systemic methotrexate can be tried only in those patients where the gestational age is below 7 weeks and beta HCG level is less than 5,000 and the sac diameter is less than 2.5 millimeters and there is no cardiac action and the presence of myometrial thickness more than 3 mm. Only in these patients we can try systemic methotrexate, but it is not advocated. So standalone treatment is not advised by any guidelines because there is high risk of complications with the methotrexate alone. This is development of AVM and sudden hemorrhage are more common with systemic methotrexate alone. Coming to treatment protocol, as in any other ectopic pregnancy, we can try single dose regime, but the effectiveness is very less. Usually the multi-dose regime will be effective. That is intramuscular injection of methotrexate 1 milligram per kg on days 1, 3, 5 and 7 with leucovorin rescue. The serum, if the serum SF, the beta HCG did not drop by 15% at the end of 1 week, the second dose should be repeated. The follow-up protocol as in any other ectopic, like weekly measurements of the serum beta HCG levels for 3 consecutive weeks. If it starts falling, bi-monthly follow-up till it becomes undetectable. And bi-monthly transvaginal scan until the pregnancy recedes completely on imaging. And while these follow-up, all these patients should be monitored for the development of any other symptoms like hemorrhage, AVM malform, development of AVM, this acquired uterine arteriovenous malformations. Coming to intragestational medical treatment, that's intragestational injections. Again, any patient is going to subject to this management should be counseled regarding this requirement, the chances of hemorrhage, requirement for long-term follow-up, and there may be a chances for surgical intervention. The chances for success rate is around 70%. That is more than systemic methotrexate. If we combine this local methotrexate with systemic methotrexate, the success rate will increase up to 88%. The patients which may respond better with this local methotrexate, when the serum beta HCG is less than 1 lakh, the residual myometrial thickness is more than 2 millimeters, and gestational diameter, sac diameter is less than 5 millimeters, and cesarean scar type 1 pregnancy. Again, the procedure we all know. We use under transvaginal guidance, we use ovum double lumen ovum as ovum pickup needle. We introduce this needle into the sac and first we aspirate the amniotic fluid to confirm that the needle is in the cavity, and then we can inject the methotrexate 1 milligram per kg up to 50 milligrams. And again, we should be vigilant for the development of any arteriovenous malformations. This is appeared as a sudden development, new development of the massive vasculature around the gestational sac, and these patients will have a sudden severe hemorrhage at any time. If this patient started developing these abnormal vasculature, then we should go for either surgical management. If available, this patient should be subjected to uterine embolization. Other drugs which can be given intragestationally are potassium chloride, which is more useful in case of heterotropic pregnancies, and all other listed drugs can be used. Coming to surgical treatment, it's successful in 96% of cases. It needs expertise and special institutions with resources. The surgical treatment for cesarean scar ectopic is a complex procedure. As I already told, it needs expertise and is associated with complications like massive hemorrhage and injury to the adjacent organs like bladder and bowel. But it is the most definitive treatment option that removes the gestation sac, offers an opportunity to repair the uterine defect. This is the most definitive treatment, but needs expertise and institutional resources. Coming to various surgical modalities, first one is sharp curetage. It's not recommended because inability to completely access and remove the trophoblastic tissue outside of the endometrial cavity. The scar tissue contracts poorly, leading to heavy bleeding, and this sharp curettage is associated with high complication rate like hemorrhage and perforation. And 52% of those patients which are subjected to sharp curettage needs additional treatments like surgical wedge resection or hysterectomy. Coming to ultrasound guided vacuum aspiration. Suction aspiration and continuous transabdominal or transectal ultrasound guidance is associated with 70% success rate in first trimester. This aspiration can be done in first trimester up to 10 weeks of period of gestation in class type 1 endogenous implantation pregnancies where there is less trophoblastic vasculature and where their myometrial thickness is more than 3 mm. And again, all these patients should be counseled beforehand for the chances for increased hemorrhage and chances for surgical intervention. And we should have pre-procedure preparation. That is, we should arrange at least 1 or 2 units of blood beforehand if in case of increased bleeding. And we should inform the anesthetist regarding the nature of the procedure and there may be a need for surgical intervention. And in cases where there's increased vascularity around the gestation sac, we should be prepared beforehand, either with the uterine artery embolization or we can also use intracervical vasopressin to decrease the chances of hemorrhage during the procedure. And we should keep ready the balloon occlusion catheters in case of hemorrhage to tackle the hemorrhage. This are coming to procedure. We all gynecologists will know how to do the section aspiration, but it should be done under ultrasound guidance, under the visualization, and we should aspirate all the gestation's contents from the cesarean scar. And after the ending of the procedure, we should wait for a few minutes to see that there is no excessive bleeding. If there is excessive bleeding, we should insert the Foley's catheter into the endometrial cavity and we inflate the balloon, Foley's balloon, at the cesarean scar site to occlude the bleeding vessels. And we should keep the catheter at least for 12 to 24 hours and then we can withdraw deflate the catheter gradually. And 6% of these women may require repeat procedure for the retained products of conception. And 6% of patients may require emergency hysterectomy and transfusion. Coming to hysteroscopy, it's a minimally invasive procedure with a success rate of around 85%. But again, it can be done on only type 1 endogenous pregnancies and up to 8 weeks period of gestation. It's characterized by low blood loss, short duration, gives a chance for fertility preservation. As this cesarean scar pregnancies are located close to the internal os, it makes harder to see them during the procedure and to maintain the distension of the uterine cavity also. It's a little difficult procedure for the cesarean scar ectopic. The risk of uterine perforation and massive bleeding will also there with the hysteroscopy. There are so many procedures are recommended, but the most commonly used procedure is hysteroscopic transcervical dissection of the gestation sac. Coming to operative wedge resection. As we already discussed, it's a complex procedure, needs expertise. It can be done either transvaginally or laparoscopically or through laparotomy, depending upon the operative choice. It have a low complication rates and high success rates, that's 98%. And the scar tissue, the other main advantage with this operative wedge resection is the scar tissue can be excised and the surrounding myometrium again reapproximated and the scar defect can be treated. But it is unknown if this practice of resuturing the myometrium will decrease the risk of cesarean scar pregnancy recurrence. Coming to procedure. So as we already discussed, if there is evidence of increased vascularity on scan, that is exogenous implantation, we should take all precautions to decrease the blood flow, vascularity in the pregnancy before undertaking the excision of the cesarean scar ectopic. That is either uterine artery embolization, or we can ligate both uterine arteries during the procedure, or we can take the help of vasopressin at the scar to decrease the chances of increased hemorrhage. So in any case, either laparotomy or laparoscopy, first we should elevate the uterus and we should do additional lysis. The uterus should be separated from all surrounding additions, and then we should open the uterovesical fold of peritoneum, and the bladder should be separated completely from the cesarean scar site. If it is not done properly, if the bladder is not separated, sorry, If the bladder is not separated completely from the cesarean scar pregnancy, the chances for bladder injury will increase. So the first step, we should do additionalysis, which separate the bladder thoroughly from the cesarean scar pregnancy. Then we should start opening the previous cesarean scar. After opening the previous cesarean scar, we should remove the pregnancy tissue completely, and we should thoroughly clean the endometrial cavity for any residual tissue or any retained trophoblastic tissue, and we should excise the scar. We should excise the scar margins, and we should reapproximate the myometrium in 2 layers. So to summarize surgical options, sharp curetage alone should be avoided. Ultrasound guided uterine aspiration and hysteroscopic TCR can be done in first trimester pregnancies where it is an endogenous implantation with myometrial thickness more than 3 mm. Operative resection is the procedure of choice in late first trimester and second trimester pregnancies, and when this type 2 exogenous implantation, when the myometrium is thin and there is increased vascularity. And gravid hysterectomy can be done whenever there is a life-threatening hemorrhage on those cesarean scar ectopics which are diagnosed in the late first trimester and in the early second trimester. And if these patients does not desire future fertility, we can offer them this gravid hysterectomy. It's a definitive management of cesarean scar pregnancy. Coming to transcervical insertion of the balloon catheter, it's an efficient, safe, well-tolerated and minimally invasive procedure, can be used between 6 to 8 weeks pregnancy. In this procedure, again, we will introduce the balloon catheter under ultrasound guidance, and we inflate the balloon at the site of the cesarean scar pregnancy. And this pressure caused by this balloon will decrease the vascularity to the pregnancy and cause fetal demise. Once the fetal demise occurs, slowly the pregnancy will the cesarean scar pregnancy will, the trophoblastic activity will decrease, and slowly the cesarean scar pregnancy will, there will be resolution of the cesarean scar pregnancy. This balloon catheter should be kept in situ for at least 12 to 24 hours and then gradually deflated and removed. Serial ultrasound examination and HCG levels are typically followed until complete resolution of the cesarean scar pregnancy. Coming to uterine artery embolization, it's a minimally invasive procedure that has been used in combination with other procedures. The anterior branch of internal iliac artery is selectively embolized. The ability to maintain future pregnancy after artery embolization is minimal. So this procedure is preserved only for those patients with heavy bleeding or there is high degree abnormality of the uterine vascularity where we expect severe bleeding. Coming to heterotropic cesarean scar pregnancy, as we already discussed, in this one intrauterine live pregnancy and the second the cesarean scar pregnancy, we can inject intragestational potassium chloride into the cesarean scar pregnancy to cause fetal demise. And according in literature, there are so many cases which showed heterotropic cesarean pregnancy treated with local KCR were resulted in healthy live births of the co-twin. These are various procedures, various treatment protocols advocated and their success rate and complication rate. So to summarize, to management decision of the cesarean scar pregnancy depends on pregnancy viability, gestational age at the time of diagnosis, hemodynamic status of the patient, serum beta HCG levels, future family planning wishes, physician skills and experience, and institutional resources. So at the time of diagnosis, if the patient is hemodynamically unstable, there is no confusion. The surgical treatment, immediate surgical intervention and control of the bleeding and stabilization of the patient should be done. If this patient is hemodynamically stable, if the pregnancy is non-viable, then we can think of expectant management. If it is a viable pregnancy, then does the patient want to continue the pregnancy or she wishes for termination? We should counsel for termination of the pregnancy because we all know the complications associated with the continuation of the cesarean scar pregnancy. But if this patient wants to continue the pregnancy, then we should look in for whether it is a endogenous type of implantation or exogenous type of implantation. As we all know, the exogenous type of implantation is associated with more risks and uterine rupture in first and second trimester of pregnancy itself. If it is endogenous type of pregnancy, then we can manage all these patients in a high-risk obstetric unit with a careful monitoring till term, and we should do electro-cesarean section at 34 to 35 weeks of pregnancy at level 3 or level 4 institution where all facilities are available. If this patient want to go for termination, if it is first trimester, medical or surgical, anything. If it is second trimester, surgical treatment. Coming to future pregnancies, there's increased risk for recurrent cesarean scar pregnancy and with its associated severe morbidity. There's a 5 to 40%. All these patients with cesarean scar ectopic should be counseled for recurrence of this pregnancy and should advise for either long-term or permanent contraception. All these patients should avoid pregnancy at least for 1 to 2 years. And during pregnancy, if she conceives the second pregnancy, an initial ultrasound is recommended ideally before 8 weeks to confirm the intrauterine pregnancy. And the management should be done as follows. To summarize, prevention is better than cure. So we should try to decrease the incidence of cesarean sections, and during cesarean section also we should improve our cesarean suturing techniques, and electro-cesarean sections and second-stage cesarean sections should be avoided, and the patient general condition should improve so that the poor wound healing will be avoided. The early transvaginal ultrasound should be done on all those patients with previous cesarean delivery to rule out cesarean scar ectopic. No expected management except in failing pregnancy with HCG titers less than 2000. In hemodynamically unstable patients, immediate surgical intervention. In early first trimester, medical management combined local and systemic, or less invasive procedures like ultrasound guided suction evacuation and hysteroscopy. In second trimester, surgical excision and gravity hysterectomy. And all these patients should be followed up for complete resolution and development for any late complications like AVM development. This is a guidelines provided by Society for Maternal and Fetal Medicine. Recommend against expectant management, suggest operative resection, ultrasound guided uterine aspiration can be considered. They suggest intragestational methotrexate for medical management without other treatment modalities. They recommend again a systemic methotrexate as a standalone treatment, and electrocesarean around 34 to 35 weeks gestation. Thank you so much.
Thank you, Dr. Aruna, for such an elaborate and in-depth coverage of CSP. So can we have very quick comments from the chairpersons because we are running a little late. So can we have a little comments from the chairpersons, please?
Thank you, Aruna madam, for your elaborate explanation about cesarean scar ectopic. Nowadays, we are seeing many cases of cesarean scar ectopic because of the medical termination of the pregnancy following 1 or 2 seizures. So they will take on their own over-the-counter or with RMP doctor, and they will come to us present as an intractable bleeding. And when we do ultrasound examination, there will be a decay or indentation at the level of the scar with the presence of chorionic tissue and the bleeding. So most of the times they come after taking first trimester termination of pregnancy with the tablets. So I have seen 3 cases, 3 of them came to me after taking medical MTP pills outside. So, and we did 1 case hysterectomy. It was diagnosed at around 14 weeks. We did laparotomy, but there is intractable bleeding. So we couldn't control by suturing the lower segment. So in such a case, after taking the consent from the patient relatives, as she was second gravida having 2 children, we did hysterectomy. So 1 case we did with the help of advanced laparoscopic surgeon. We put an Hegas dilator inside the uterine cavity. We did wedge resection of the scar, and we did laparoscopically suturing. But the more complication during laparoscopic wedge resection is bleeding, which it should be controlled by uterine artery ligation prior to attempting the wedge resection. Or you can give intrasac vasopressin. So in one case, we did after without any uterine artery ligation, and after putting a Hegas dilator inside the uterine cavity to prevent suturing of the posterior uterine wall. Thank you.
Thank you,
what
Dr.
is your
Radha.
experience, Madam Aruna, Madam? How many cases you encountered in the recent past?
Yeah, in last 6 months itself, I have done around 6 cesarean scarring. It's increasing in incidence. All of them are referred from the colleagues. One is failing pregnancy. All types of cesarean scar pregnancy I have seen. One case, as you told, it's managed
it is because
outside.
of single layer closure of the cesarean scars nowadays, and more number of elective cesarean sections are done nowadays in AP because of so many, so many
Yeah,
reasons.
these
I
elective
disagree. I disagree.
No,
Neha,
Niharika.
we'll have your inputs and then we'll move on. I think
Telangana
because we are
followed by
running really
Andhra,
late.
highest number of elective seizures are done. So it is according to Foxy report only, Niharika. So in Telangana, 55%,
So I'm just saying,
and
don't
in Andhra
generalize.
Pradesh,
That's all I'm
around
saying.
45 to 50%.
Yeah, that is true. And recently we had also discussion with Robson, no?
Yes,
That
madam.
time also, I think she had presented our Kiranmai.
Okay.
The sections are increasing in Andhra Pradesh. The patients are requesting for elective cesarean.
So
That's the
because
main
of
reason for
Arogyashri and other insurance policies, madam,
yes,
these cases are increasing.
yes.
So one region in is Arogyashri in AP.
Yeah. Sneha ma'am, can we have your inputs and then we'll proceed?
I'm really amazed by the presentation. Dr. Aruna Kumari really has extensive experience as well on this topic. So it was an excellent deliberation. Hearty congratulations to you, Dr. Aruna Kumari.
Thank you so much, ma'am. Thank you so much.
And may we move ahead?
Yes, yes, ma'am. Yes. Sahiti, can we have the slides, please? So now we are going to continue with the second session for today. The topic will be a difficulty at C-section. So we are going to see the end of two spectrums. So we have seen the result. Now let's see how we can prevent it by doing a C-section properly and other problems that we will face at a C-section. So let me introduce the chairpersons for this session. Dr. Narsavani, she's the Vice President of Bhimvaram Obstetrics and Gynecological Society and a consultant at SVR Maternity Hospital, Bhimvaram, with 24 years of gynae experience. Welcome, madam. Next, Dr. Lakshmi Irinki, she's a consultant at Sri Lakshmi Hospitals, Bhimvaram, and the inaugural president of BOGSY. And she's done her MD from JIPMER and participated in various national and international conferences. Welcome, Dr. Lakshmi. Next, Dr. Parvati D. She's a professor and HOD of Rangaraya Medical College, Kakinada, and professor and HOD at GMC Srikakulam right now. And she's attended as an external examiner in many state postgraduate examinations. Welcome, madam. So now I hand over to the chairpersons to introduce the speaker, Dr. Sujata Dalvi. May I request Dr. Narsavani to introduce the speaker for this session. Ma'am, kindly unmute yourself.
Namaste, ma'am. Good evening, all. At the outset, I should thank Dr. Sneha, ma'am, for giving me the opportunity and also all the best for your aspirations, ma'am. And also, I thank you, Dr. Niharika, and other coordinators who involved in this event for making me a participant of this scientific session. And coming to the topic of this session, that is difficulties at cesarean section. Of course, it is a common procedure as we all obstetricians are doing nowadays, but it's considered as a simple and very safe procedure. It's an alternative to vaginal birth, difficult vaginal birth. But sometimes we face difficulties at cesarean section also, where the entire purpose of cesarean section, that is safe child and mother, is defeated. So we are at failure sometimes. So that leads to fetal and maternal complications. And according to this difficulties at cesarean section, the literacy is less available now. And we are facing the cases, difficulties. Every difficult case will teach us a new lesson in that area of difficulties. And our literature is less available regarding these cases of difficulties at cesarean section, only a few cases and few case studies and also experts' opinion is available. And today we have our honorable guest speaker, Dr. Sujata Dalvi, who is one of the great experts in this area and who is going to deliberate her lecture on cesarean section difficulties. And Doctor, I am very privileged to introduce our guest speaker, Dr. Sujata Dalvi, who is a consultant and obstetrician at the Mumbai hospitals at various areas and Ginagil, Saifi, Bhatia, and St. Elizabeth's hospitals.
That's fine,
And
doctor.
she is the Honorable Associate of Navjatji Wadia Maternity Hospital and the Treasurer for Mumbai Obstetrics and Gynec Society. And she is the Associate Director of Jogi and President of Mumbai Society of Menopause Society and past Secretary of the AMOGS, that is Association of Maharashtra Obesity Societies. A warm welcome to you, ma'am.
Yeah, thank you, Dr. Navarasani. Can I screen share the thing?
Yes, we can see your screen, madam.
I could see that. Only thing I want to. So before I start, I would like to express my gratitude to Dr. Sneha, who is AMOGS Emergency Obstetric Committee Chairperson, with her team, Dr. Niharika and Dr. Shaileja. Niharika from Vishakhapatnam Society and Dr. Shaileja from Vijayawada Society. And of course, I would also like to express the words of wisdom which were given by our chief guest, Dr. C.N. Purandare, and of course, Dr. Rajendra Singh Pardesi. So before I start off, I would like to express and wish best wishes to Dr. Sneha for her future endeavor in Foxy, and of course Vidya Thobi, who is also there in this, there as a moderator for her future endeavor in Foxy.
Thank
So
you,
today I'm going to be speaking on difficult delivery at C-section. So if you go to C, you find nowadays rising rate of C-section.
Ma'am, if I may interrupt, can you put it on slideshow mode? We are not seeing the slideshow. We are seeing the normal view.
Now you can see, correct?
Yes.
Yes,
Okay.
perfect.
Sorry. So the goal of C-section is to do no harm, neither to the mother or to the baby. And basically in C-section, the fetal journey through the birth canal, that is pelvis, is totally eliminated. The delivery is under your direct vision, and there could be a difficult or a traumatic abdominal delivery would defeat the very purpose for which you're doing a C-section. You would want both the babies and the mother to be fine when you're doing a C-section. So the key for this is to anticipate any problem and to make planning or to plan accordingly. So when to expect a trouble, the problem of anesthesia, the incision, the method of delivery has to be kept in mind. And then you have to just plan it a little bit in advance, just in case something like that happens. The fetal eye also has to be kept in mind, the presentation, the presenting part, whether the presenting part is floating or it is fixed, whether the presenting part is in flexion position or little bit of a deflex or an extension position. The induction delivery time, they say, should be less than 8 minutes, and incision delivery time, they say less than 3 minutes. But nowadays, it doesn't matter. Most of the time, the neonatologists and anesthetists are able to manage. The challenges that we face is an abdominal incision. If there is a previous scar, then there are chances that there could be adhesions. The bladder dissection may be a little difficult. You start dissecting from the lateral side. Never go in the center, because bladder could be adherent in the center. Dissect it from the lateral side, and then maybe if at all the need arises, you can do hydrodissection and dissect out the bladder. The uterine incision needs to be taken. Sometimes transverse, it could be curvilinear. Sometimes you might have to take an inverted T-shaped, J-shaped, or occasionally vertical. We nowadays don't take vertical. We generally reserve ourselves to only about transverse, curvilinear. Documentation, in case there are some difficulties that you have encountered, is very important on a discharge card. So in case patient goes somewhere else to delivery, at least that person who or she is in charge knows what exactly was the difficulty in a previous C-section. So that way they can take proper measures. Counseling is very important, and wherever elective C-section is mandatory, please counsel the patient, because otherwise they come during the emergency time when the senior staff is not available, and there could be a little possibility that they could have a little difficulty handling that patient. Feto-pelvic relationship is very important. If you have a floating head, deeply engaged presenting part, if there's an abnormal position or a presentation, If there's an extreme prematurity, the baby is very small and the lower uterine segment is not very well formed, and then to deliver that baby becomes little difficult. Multifetal pregnancy, if the presentation is not in a vertical line, there could be some difficulty in delivering both the babies. A baby has a fetal malformation. If it is detected well in advance, fine. Sometimes if it is not detected, could cause some difficulty while delivering the baby. And lower uterine segment, if it is poorly formed, or if it's a low-lying anterior placenta, or if there's a fibroid anteriorly, or if there are adhesions, that could create a little bit of problem at the time of delivering the baby. Rarely uterine anomalies like biconio uterus where fetus is in each horn. There could be difficulty in delivering the fetus because there is possibility that fetal presentation may be little difficult or may not be in a cephalic. Rare cases like approach to the lower uterine segment may be difficult, and occasionally or very rarely you might have to resort to a classical C-section if at all you find that approach to the lower uterine segment is very difficult. So difficult fetal extraction, if you go to see, is about 1 to 2% of the cases. Now coming to the most common, that is delivery of the floating head. If at all you have a floating cephalic presentation, it is difficult to grasp the fetal head. It is difficult to control, and traction is also a little bit, you may feel you have held the head, but traction becomes little difficult. It cannot be readily pulled or it cannot be guided through the incision until and unless you keep a pressure from one side and give a steady pressure. Sometimes the uterine forces do not push the head towards the incision, and sometimes the head just turns away and it just goes laterally. If there's too much of a fundal pressure, if it is given by someone, then head pushes laterally and baby becomes an oblique rather than baby's head coming out through the incision, and thereby there could be a change in the presentation. In case of an excess liquor that you are expecting it, take a very small incision. Don't take a very big incision. Take a small incision. Drain that liquor slowly and gradually. At the same time, steady the fetal head by keeping the hand over the fetal head, and then you extend the incision. Then the head will not slip here and there. In case a need arises, if at all it is difficult, you can use a vacuum extraction, or you can use a forceps blade. The short blades are very useful. Occasionally, one blade can be used. We call it as a vectis. And once you have griped the head, then steady fundal pressure is important to extract the fetal. Beforehand, only if you have not had a proper grip on the baby's head, and then somebody gives a fundal pressure, fetal head is bound to go on the lateral side. Occasionally, you might have do an internal podalic version and breech extraction in case all these measures fail or you're not comfortable with all these measures. So forceps blade are always there on our C-section trolley. So blades, you need to see whether they are of the same pair. Nuances, the lower blade needs to be applied first. That is, the posterior blade you apply first and then gently apply the anterior blade. It's not like left and the right. And then you have to then gripe the fetal head and then slowly and gradually deliver the fetal head and bring it out over the incision. So this is what we have just try to do it. You try and put the fetal head. Same thing. The lower one, the posterior one goes first. Your hand has to be lower down, and then take the anterior blade, and then you apply it very gently. Then try and lock the blade, and then do a fetal extraction. And I'm sure you're able to do it. It's not very difficult. Only thing you just have to try doing it, and it works out very well. For routine cases also, the fetal, this forceps is always there on our trolley whenever we are doing a C-section. In case you're not comfortable with the forceps blade, you can use vacuum, the regular vacuum that we have it, but we have nowadays an hand vac, whereby which you can put a silastic cup and immediately you can raise the fetal negative pressure, slowly and gradually apply it. Make sure that the uterine wall or the incision is totally free of this thing. Raise the negative pressure immediately, and then slowly and gradually you just have to give a negative pressure and slowly and gradually just you have to make sure that there is nothing which obstructs the way. The doyens, as usual, when you remove even the regular head of the baby, also you remove the doyens. The same way you try and remove the doyens, and slowly and gradually you just have to direct the fetal head and little bit.
Ma'am, we are losing you. The signal seems bad.
Yes, Sujata ma'am, I think your internet is very unstable.
Ma'am, probably switching off your video will help.
Madam, please. No, please switch off. Try switch off your video and then try, madam.
Switch off the video. Videos are already
Now it's good, ma'am.
Yeah.
Videos are already switched off.
No,
No, your video, ma'am. Your video. Your
Yeah, screen video is also already
your video. This
your face.
Video. So
my face you talking?
Yes,
Yes, ma'am.
That will help, madam.
One second. Let me, because I've made that into a small screen, so I can't even see my face.
Ma'am, just click
Now
at the
can you-
bottom of your screen. You will get mute, unmute button. So besides that, you'll have the start and stop video button. So you could just use that.
It's not there. Now can you hear me, but?
Yes, ma'am. It is better now. It is
It's
better.
better?
Yes.
Then let me, because maybe probably the video was coming in the way or whatever it is. Okay. Anesthesia with good uterine incision, that I've already said. Anesthesia with good relaxation is very important. Decrease room for an intra because there's decrease. Hello? Because there's decreased room for intrauterine in manipulation, and if there's a failed instrumental delivery, it further impacts the fetal head. So you have to keep that thing in mind. So gently push the flat of the hand. Whenever you're trying to deliver the fetal head, gently push the flat of the hand, lower hand, and put it in a cone-shaped manner between the fetal head and the pubic symphysis and try and deliver. Don't fan it out that much because there's hardly any space as such. Vaginal disengagement of the head is of very important. So if you have an assistant, if you have anticipated, then you can keep an assistant ready who is there with the gloves and everything. And assistant will little bit push the fetal head to meet the operator's hand, and that's why you can deliver the baby's head as such. So push beforehand so as to maintain the flexion. You don't pull it, but you let the assistant push it so the baby's head remains in a flex position, and that way you can try and deliver the deeply engaged head. 3 or 4 fingers or a cup-shaped hand is necessary so far as from the assistant head is concerned, not 1 or 2 fingers, because if you say take 1 or 2 fingers, then it puts a pressure only over a particular part of a fetal head, and that can cause some amount of a damage, or maybe skull fracture is possible, and that is the reason. So this is how you just try and put the fetal head and keep it in a flex position. Try and meet your assistant head with your hand and then try and deliver the fetal head. And this is how you can try and deliver the deeply engaged fetal head. There is another way you can do it if at all you are anticipating that, like a failed vacuum, failed forceps, and then now you have taken up a patient for a C-section, then you keep it ready. That patient can be kept in a slightly modified lithotomy position or a supine frog leg position or a Whitmore position, so that the fetal head automatically is easy to deliver. But that if you're anticipating, if a patient is in a flat position, it is very difficult to raise patient's legs and then give her that sort of a position. So to avoid all that, Dr. Arul Kumaran had come out that we can do what we call it as a reverse breech extraction, whereby which you insert the hand, reach out till the fundus of the uterus and find out for the feet of the baby, grasp both the feet and pull both the feet out, and that's how you try and deliver the patient, deliver the baby, what we call it as a pull method, so as to, and as far as possible, keep the head in a flex position so as to avoid an hyperextension, and that we call it as a reverse bridge. When the reverse bridge is possible, provided there is enough liquor. If most of the liquor is drained out, sometimes reverse breech extraction is little difficult, but if at all there is enough liquor, your hand can reach up to the fundus, try and hold both the legs of the fetus and gently try and deliver the baby, what we call it as a reverse breech extraction. Occasionally, what we have it is a push method or a pull method. So there is a controversy whether you should try and push the baby's head and deliver, or you should try and pull that. They said push technique takes a little longer time. They said it involves a little more greater blood loss, and there are more chances of vaginal or uterine injuries requiring suturing. And fetal injury rate in both pull and push technique is more or less the same, but it's only that the maternal morbidity is little more in a push technique. So one has to be little careful when you're trying to push the fetal head from below as compared to the pull technique. So if at all you are comfortable with the pull technique, there is enough like your hand can reach fundus, nothing like it. There are at times in a deeply engaged head, what we call it as a shoulder sign. That is, you take an incision and the shoulder just pops out, So what assistant can do is assistant can push the shoulder up and surgeon can directly extract the fetus, or we deliver the baby by a shoulder extraction, what we call it as a Patwardhan's maneuver. Patwardhan's maneuver are of two types. One, if the back is posterior, then you remove one arm and you remove same-sided leg, and then you take opposite leg and then opposite arm, and then finally you deliver the head. If the back is anterior, it is difficult to take one side arm and the one side leg. So you remove both the sided arm and then you try and deliver the baby's trunk and the legs, and then you skip out. Whether it is a modified Patwardhan's or Patwardhan's, there is little controversy. We call it as a two type of maneuver where when the back is posterior and the back is anterior. Occasionally, abroad, they have what is known as a fetal disimpacting system or a fetal pillow, which is available, whereby which you keep it ready, anticipating that there could be problem. You apply it onto the fetal head and then try and increase the pressure. And before the incision is taken, you inflate that fetal balloon or fetal pillow with 180 cc of saline so that the fetal head automatically comes up. And then you try and deliver the baby's head and then deflate the balloon post-delivery and gently remove it. This is what is a balloon which is there. It's a silicone balloon which is connected with the syringe, but you need to anticipate this. Okay, you could have this problem, and that's how you need to apply it. If you can't anticipate it, then it is little difficult to be applied at the last moment. This is how it gets inflated and you can use it. It is not available in India, but it is available abroad. So fetal head elevator, there are at times people have used fetal head elevators, that is obstetric spoons or a head extractors known as an obstetric shoehorns, which occupies less space and they are narrow and it is easier to get around a tightly impacted fetal head. Gently introduce this instrument, whatever it is that is between the fetal head and the lower uterine segment, elevate it out of the pelvis, more towards the cephalod, and then you try and deliver. And if this is not possible, you can try and take inverted T-shaped incision and try and deliver the fetal. These are the fetal spoons which are available, but they are very narrow, but you have to introduce it very gently. You cannot just introduce it like that because it causes more trauma than trying to help you out. Whenever you have a patient with a breech, you need to have an adequate incision. Mind you, breech also, it's not very easy to deliver, but it's not that difficult also. But you need to have an adequate incision. You handle the fetal limbs with a natural range of the movement. Support the trunk with a pelvic girdle. Never hold the trunk with because you could damage the liver or any intra-abdominal organ. Always better to hold the baby's trunk with the pelvic girdle. If it's a preterm breech, then one has to be little careful while handling the baby because they are more prone to injury. As lower uterine segment is also little thick wall, it is narrow and it retractile over the large after coming head. After coming head of the breech is little bit on the bigger side as compared to the rest of the part of the body, and it may be little difficult to remove it, and that's the reason you need to have an adequate uterine incision. Baby with a transverse lie, you need to have a skilled or an experienced person to deliver that. In case one is not that much experienced, there is never, you could ask for a help. There is no shame in asking for a help. You can carry out either an external cephalic version if the membranes are intact. Otherwise, you take a liberal incision, try and feel for the back of the baby. And from the back, you go over to the feet of the baby and then try and hold the feet of the baby and deliver what we call it as an internal podalic version. In case baby's hand, when you're taking an incision in a transverse lie, baby's hand comes out, reposit the hand back. Don't try and deliver the baby when the hand comes out. Reposit it. Try and hold the baby's leg and remove it. That becomes little easier in a transverse lie. So it's always better to know which side is the head, whether it is on the right side, whether it is on the left side, whether the transverse lie has become an oblique or whether it has become, occasionally it does become breech also. So you need to just know it before, a little bit beforehand or maybe on table. Extremely low birth weight babies, here the uterus is very less distended. Lower uterine segment is not very well formed. That's why the myometrium is thickened. Lower uterine incision, if you say you need to take a little deeper incision, so there is little more blood as compared to otherwise. Incision may be inadequate because if you try to stretch the incision, you could damage the uterine vessel also. There could be chances that you could lacerate the fetus and extend the incision an incision might get extended to the uterine vessel. If it's a small uterus, then sometimes bowel also keeps on coming in the operative field. So one has to be little careful whenever you're handling an extremely low birth weight babies or an IUGR or FGR babies where the babies are small, one has to be little careful whenever you're taking an incision. Small fetus, as what I said, delicate bones and delicate tissues which are very prone to injury, one has to be little careful. Don't just keep on pulling the baby here and there. If at all you have difficulty, think where is the difficulty and try and negotiate the difficulty rather than pulling the baby randomly, because you can cause more injury to the baby as such. Adequate incision is very important. If at all, you should take it, what we call it as a transverse and little bit going upwards. Don't go laterally, then it gets extended into the uterine vessel. Occasionally, you might have to take a vertical incision if at all lower uterine segment is not very well formed, and if the uterus is very small, but it is not that you need to take in vertical, you can manage with a transverse incision with little bit going upwards as such. Multifetal pregnancy, you need to have a proper information so far as a live presentation is concerned, and of course the placement of the placenta. So you need to have a sonography which is done at term. So at least you know what exactly is a fetal life. You need to take care whenever you're delivering the first fetus. And if at all, you need to make sure that the second fetus also you deliver on time, because occasionally you could have a constriction ring and then you might have difficulty in delivering the second fetus. Anterior low-lying placenta, these are the pathologies. Sometimes you do encounter, if at all, you find that the placenta is anterior and it is low-lying. Of course, I'm not talking about previous C-section where the placenta is anterior. There could be a possibility of placenta accreta or increta, but you try and find out the area which is free of the placenta. Whenever you have opened up the incision, try and insinuate the finger between the placenta and the uterine wall, rupture the membrane and access the fetal part as far as possible. In a rare circumstances where the placenta is anterior, you're not able to insinuate your fingers between the placenta and the uterine wall. Sometimes you might have to go transplacental. Then you have to be very quick going transplacental and try and deliver the fetus as early as possible. Otherwise, there could be lot amount of a bleeding which can happen. If there's an anterior fibroid which is especially present, you need to have an exact mapping of the fibroid just before when you're planning a patient for a C-section. Incision should be taken in such a way that you try and avoid the fibroid as far as possible. Sometimes you might have to go through it. Then in that case, it is better that you do quick myomectomy and then go through the lower uterine segment and try and deliver. But here you have to be very quick about the whole thing. And then you make sure that enough blood is ready and there are enough people to help you around, because a single person, single-handedly, it's difficult for that person to manage it. Occasionally, you might have to do a classical C-section, but proactive prophylactic treatment for PPH has to be kept in mind and has to be kept in ready just in case the need arises. Maternal morbidity, as what I said, uterine injury, uterine laceration, vaginal tear, damage to the uterine vessel and injury to the lower urinary tract. These are the vaginal morbidity. One has to be little careful. Not that these cannot be managed, but it is always better to avoid as far as possible. And you should keep it in mind and you should be little gentle, quick but little gentle, and for which you need a little bit more of an experienced person who is handling the same. Injury to the newborn, impacted head, there is an increased risk. Head laceration, fracture skull, neck, long bones, injury to the brachial plexus, very common whenever you're pulling the fetal arms as such. Spine injury occasionally to the spinal cord. Sometimes there could be damage because of an asphyxia. Deep, uncontrolled, inadequate and inappropriate uterine incision and very hasty and difficult fetal delivery can cause some injury to the newborn. So you have to be little careful. There's no need to hurry about the whole thing. No need to panic. You should think and then try and deliver and which way, so that you will cause least damage to the mother as well as to the fetus. Prevention, avoid hasty and difficult fetal delivery. One should be well versed with difficult maneuvers. So that is the reason we do have all these exercises. We do have these programs and the workshops whereby which they teach you, because these are the things which doesn't happen every now and then. And these are something like an emergency where it is difficult for anybody to learn or something until and unless you have learned in a workshop. So that is very important. assistance is necessary. So in case you are anticipating, always ask for an assistant to have a safe delivery. Always ask for somebody who is senior in case one is not very well versed at. Little formal training is necessary, and you need to have skills and drill protocols. And that is the reason quite a few workshops do have something like this, so that in case it happens in an emergency, you are not, you would be able to handle it better. So guidelines are anticipate potential difficulties, plan management so as to prevent any of the morbidities, paucity of literature, case studies, expert opinion, and you have only small case series. As what I said, these things don't happen every now and then. So you do have a case studies or at the most some case series, 3 to 4 cases of a similar type, but you will not have an original paper of many cases as such. Mobilization of proper resources is very important, not only personnel, but equipment. You should have that type of an equipment ready with you at that time. And of course, you need to have an experienced personnel. Plan an incision, whether it is a skin incision, abdominal wall, uterine incision. If at all the need arises, please extend it in such a fashion that you are able to deliver the baby properly without causing any damage to the mother. And sharp dissection for the adhesions is very important rather than blunt dissection. Blunt and you try and push it and you're bound to damage any of the organ, especially the bladder. So you need to be a little careful whenever you're doing dissection for so far as in adhesions are concerned. Accomplish atraumatic fetal delivery, you need to have a good skilled neonatal support. Very important, because sometimes a baby comes out, you are struggling, baby comes out, and you need to have a good neonatal support. And that is the reason you need to deliver the baby not by force, but by skill, because in the end, what you want is a healthy mother and the healthy baby. Thank you so much.
Thank you so
Thank you,
much,
Dr. Sujata, for that a wonderful presentation, a lot of practical tips to the delegates. Dr. Lakshmi, can we have your inputs, please?
Yeah, thank you so much, madam, for an elaborate presentation. And you have gone through all the different aspects of difficulties we encounter during cesarean section, especially approach and access to the lower segment, difficulty in delivery of the fetus, and also the placental problems. Thank you so much, madam. And one point I would like to add, share my experience about a fibroid complicating pregnancy, a huge big fibroid which was occupying the lower uterine segment entire and also the lower part of the uterus. And the baby was in transverse line. So this is a O negative group patient. So we had kept 5 units of blood ready. We had assistants as well, a senior gynecologist, myself, and another help I had taken. And I had to quickly do a myomectomy of that size, and I had to quickly grasp the fetus and deliver the baby. Luckily, the baby was fine and also the mother, but she had to be transfused almost 3 units. So thank you so much, madam,
I also had
for
one
giving me this
patient I was
opportunity.
called. I also did myomectomy, and because patient was not mine, I was assisting. So I told that obstetrician, now you apply a forceps and deliver the baby. She didn't know how to apply a forceps at the time of C-section. So I had to come from that side, put in a forceps and deliver. So this is what happened. That's the reason I'm telling you. It's very easy to apply forceps during C-section. It's not that forceps has to be applied only for vaginal. They can always try so that they don't, in case some difficulty arises, they know how to apply forceps, at the time of C-section also.
Yes.
Thank you. I thank all the chairpersons and Dr. Sujata ma'am for a wonderful session. Let's move on to the panel discussion on antepartum hemorrhage. We have none other than Dr. Sneha Bhuyar. She's the chairperson for the AMOGS Obstetrics Emergency Committee. She's already been introduced. Welcome, madam, once again. And we have 2 experts for this panel. Dr. Vidya Tobi, she's a professor and former HOD, Alameen Medical College, Vijayapur, Karnataka, and also the president of Kasoga 2023 and State Advisory PCPNDT Board, Karnataka. Madam, you have a very long list of accolades. So I think all of us know you. So welcome, Dr. Vidya. Next. Dr. Venkataramana, he is the president of the Kurnool Obstetrics and Gynec Society, and sir is trained in laparoscopy, and he's a very senior practitioner from Kurnool. Welcome, sir. Now we have panelists, Dr. G. Sudharani. She's working as an associate professor at Government Medical College, Nandyal. Next. Dr. P. Rajalakshmi. She's also associate professor in Government Medical College, Nandyal, and also a Dhira master trainer. Next. Dr. A. Sridevi, she's an associate professor at GMC Ongole. Next. Dr. Deepa, she's a consultant. Next. Dr. Nalini Katta, she's a consultant obstetrician and laparoscopic surgeon at Ravi Nursing Home, Malikipuram, with 14 years of experience. Next. Dr. Nirupama P, she's a consultant at Sri Gautami Nursing Home and with areas of expertise in laparoscopy and hysteroscopy. Next. Dr. Sandhya A, she's the chief consultant and laparoscopic surgeon at senior IVF specialist at Arka IVF, Srikakulam. Next. Dr. K. Bhagyapriti, she's a senior resident at Government Medical College, Srikakulam. Next. Yeah, so we have all the panelists introduced for you. Dr. Sneha, over to you.
Yes. Thank you so much, Dr. Niharika. I hope I'm audible, and I'll just make my presentation in slideshow. And
yes, ma'am. Yes, all good.
So, without much ado, I straightway start my panel discussion. So, all of you know, all of you are experienced, and so we will not discuss what antepartum hemorrhage is and just go ahead with the case discussions. So I welcome all my panelists and of course the expert panelists, Dr. Vidya Tobi and Dr. Venkatramana sir. So we have this case for you, Dr. Sudharani. Do we have Dr. Sudharani? The first panelist, Dr. Sudharani. Can anybody take up this case otherwise? Hello?
Any of the panelists can take it?
Can I see all the panelists here? Can you please put on your videos? Yeah, and I think they need to be
request the panelists to rename yourself. We can see only doctor, so it's difficult for madam to.
Yeah. Please, at least please put on your videos. And do we have Dr. Sudharani here? No? Okay.
Ma'am, I don't see her.
Okay. We can go ahead. Anybody can take up this case. We have primary gravida, 5 months pregnancy, and she comes to you with history of bleeding. I'll just put on this. Yeah. So bleeding per vagina in the morning at home, which was painless in nature, and it just happened spontaneously. So on further inquiry, she revealed that she has had spotting during early pregnancy also. So on examination, she is normotensive, non-anemic. The uterus is almost 20 size and relaxed. The fetal parts are well palpated and fetal heart is well heard. At present, there is no bleeding. So what is your diagnosis and what further investigations would you like to do for confirmation of your diagnosis and management, of course? The panelist. I would ask the expert to make the last comment, as you know, when we conclude the case. Do we have anybody here? Harry, what has happened? All my panelists.
It may be
Dr. Deepa, Dr. Nalini, Dr. Nirupama, Dr. Rajya Lakshmi. So, Dr. Rajya Lakshmi.
Ma'am. Good evening, ma'am. This is Dr. Deepa.
Okay, go ahead, please.
So this this could be a case of placenta previa, ma'am. Could be. So I would like to go for I would like to go for an ultrasound, obstetric ultrasound, preferably a transvaginal scan to correctly identify the type of placenta previa.
Correct. So do we label at this stage as placenta previa?
No, ma'am. It should be called a case of antepartum hemorrhage only, unless our diagnosis is confirmed. It is only a case of antepartum hemorrhage because it could be a case of a marginal sinus rupture also. So, so until we clarify and confirm it on ultrasound.
Okay. So how do you go ahead with ultrasonography? And I mean, how do you label? When do you label the patient as having placenta previa?
On a transvaginal ultrasound, if the margin of the lower margin of the placenta is within 20 millimeters from the internal os, then it is called as a case of placenta previa.
Yeah, that is 2 centimeters, right?
Yes, ma'am.
Okay, so this actually is a patient who has got, recurrent early pregnancy hemorrhage, we would call it as. Okay, usually placenta previa, we label it in the late second and third trimester. Okay, so on ultrasonography, you have done that, you find that the placenta is low lying. So how would you go ahead with the management of this patient?
So we need some more investigations, ma'am. Most important investigations being blood grouping and typing and a complete blood picture. You already mentioned that she's not anemic, but still I would like to know her blood group. So that blood group, because she's come with an episode of antepartum hemorrhage.
Yes.
Then.
And of course, you would like to rule out other causes of bleeding, right?
Yes, ma'am. Yes.
Okay, so you will also go for, the coagulation profile and all this. And by the time, I mean, before you confirm it to an ultrasonography, maybe even if you confirm it to an ultrasonography, you would still like to go for all these investigations, correct?
Yes.
Now, suppose at 20 weeks, you find that the diagnosis is low-lying placenta. Is there a role of osteitis, that is cervical cerclage? Would you advise her tocolysis? And what precautions you would advise the patient?
There is no role of prophylactic cerclage in a case of antepartum hemorrhage at all, ma'am. Absolutely no role of prophylactic osteitis.
Yes, yes. The message has to be very loud and clear that there is no role of cervical cerclage just because it is placenta previa, because osteitis or cervical cerclage has its own eligibility criteria, right? So what about the role of tocolysis?
If you are thinking of giving her prophylactic steroids when the patient is between, say, 28 to 34 weeks of gestation.
No, we are talking about our patient. Our patient is only 20 weeks. We are managing this patient.
There is no role of tocolysis also in this case, ma'am. No.
Okay. So your aim is to rule out this pregnancy.
Hello, Sneha. Can you hear me?
Yes. We are going to have your expert comments, my dear.
Yeah. No. Just I wanted, you were discussing about tocolysis.
Yes.
If patient comes to you with uterine contractions, and definitely sometimes we want steroid to act. And second thing is, whenever there are uterine contractions, usually the placenta it separates and still more bleeding is there. So routinely we are not advocating tocolysis in any patients of placenta previa, but in some patient we can think of use of tocolytic drugs.
Yes, but here the patient is only 20 weeks, so there is no.
So now it is 20 weeks, but in general I am talking about tocolysis in placenta previa.
Right.
Yeah.
Right.
So it has we don't use because there is lack of proven benefit. And no, we may use usually nifedipine. And they say that endomethacin should not be used. Yes. Hello? Yes. So they say that endomethacin should not be used because of its inhibitory effect on platelet function, as well as potential adverse effect on neonate.
Yes,
that is what I want to convey, because the tocolysis.
Yes, but these all things come into discussion when our patient has contractions, but this patient has got less bleeding. Okay, so you're right. When the patient has contractions, definitely we have to take this pregnancy ahead. So Dr. Deepa has very well suggested that you are for ultrasonography and as
34 weeks. 34 weeks.
Yeah. So our patient is only 20 weeks, so we have to take her up to 34 weeks at least. So naturally, meanwhile, you have to advise her to avoid certain things. So what are they, Dr. Deepa? What precautions do you give to your patient? Dr. Deepa?
Yes, ma'am.
Yeah.
If you're planning an outpatient management, after a day or two of inpatient management, if the bleeding has settled down and the patient is fine, we usually plan an outpatient management provided she stays within a half an hour distance away from the hospital. And we advise them to avoid intercourse. Once the diagnosis of placenta previa has been made, we advise them to avoid intercourse till delivery.
And internal examination as well.
Internal exam, yes, ma'am. Or internal examination should not be done in these patients.
Okay. And then you have to keep her blood reserved all the time. You have to warn her about what, if at all she bleeds any time, even if she has spotting, she has to report to the hospital. Okay, so what is your, what is your plan for this patient? How long you want to take her further, and how do you plan her management as far as the delivery is concerned?
Depends upon the type of placenta. Usually, if it's just an uncomplicated placenta previa without any morbid adherence, they can be allowed to continue the pregnancy till 37 weeks, ma'am. We can allow them to go up to term.
Yes. Yes, that is what that we have to continue this pregnancy at least till term. That is, we take it as 37 weeks, provided she doesn't bleed in between, right? So with all the precautions, all the things, including blood, keeping everything ready. Meanwhile, you take this patient up to 32 weeks. Once again, you go for ultrasound, confirm that yes, it is still placenta previa. And then, of course, there is no morbidly adherent placenta. Then you can give her antenatal steroids, magnesium sulfate, and maybe you try to pull her on. And then how do you go for surgery? What precautions you want to take before surgery, during surgery?
If it is an Rh negative patient, again, if it is an Rh negative patient, we give them an anti-D injection, ma'am, in addition to the prophylactic injection that we give routinely at 28 weeks. For any episode of bleeding, again, we give another dose of anti-D.
Okay.
And
during surgery, anything you want to, you have planned this, the cesarean section for the patient. You have reserved blood products, everything. Then how do you take the incision?
How do we plan the incision, ma'am? I'm not able to hear your question. How do we plan the incision, ma'am?
Yes. What kind of incision you should take? The abdominal incision, the uterine incision. What precautions do you take during the incision? Yeah.
In cases of major placenta previa, like central placenta previa, etc., we usually prefer to give a midline, subumbilical midline incision, and preferably under general anesthesia. To provide for adequate uterine relaxation, and try to keep the incision a little high above the level of the placenta so that we don't incise the placenta, and try to go as Sujata madam had said, we should try and put our fingers in between the placenta and the uterine wall, go down, feel the membranes, and then rupture the membranes and get the baby out. If possible. If it is a proper central placenta previa, then we keep the incision a little high, go there and get the baby out.
Yes. Perfect. And then, of course, you have to see to it that she doesn't bleed post-operatively, because lower segment placenta, huge sinuses, you have to give adequate and effective uterotonics, right? So this is the same patient who is very prone for PPH. Okay. What else you have to do in addition to uterotonics? Uterine balloon tamponade, even the hemostatic sutures, even the compression sutures, and you may have to go even for the stepwise devascularization also. So all these precautions you have to take while planning any surgery for this patient. So now I would ask the experts whether you want to add anything, Dr. Venkatramana sir and Dr. Yeah, please.
Madam, if it is a post-cesarean pregnancy, we have to rule out any adherent placenta. We have to take care of, and you should be the other members also will be ready to help the surgeon for internal
this patient is a primary gravida.
Okay.
Yeah. So please go ahead. Anything else you want to add?
Madam, in uterine artery embolization,
yes,
preoperatively, that can also be done, madam, to prevent the bleeding.
Perfect. That is what we have mentioned here. If facilities are available, interventional radiology for uterine artery embolization. So definitely, I think that should be the comprehensive management for this patient. So thank you so much, Dr. Deepa. Dr. Vidya and Dr. Venkatramana, our experts, have added values to this discussion. So we would go ahead with the second case now, Dr. Rajalakshmi. Dr. Rajalakshmi.
Yes, madam. Good evening, madam.
Yeah, good evening, my dear. This is a case.
Thank you for giving me the opportunity.
So welcome. So this is the second Gravida para 1 with 9 months amenorrhea. She comes to you with labor pains. Her pulse rate is 100 per minute. Blood pressure is normal. No pallor, no edema. Uterus is full term. Contractions 40 seconds every 3 minutes. The contour is well maintained. Head is fixed and fetal heart is also good. The patient started bearing down. But there is spontaneous rupture of membrane. Okay. So there is a fresh gush of bleeding. With sudden drop in the fetal heart rate. What is your diagnosis here? And how will you manage this?
Madam, the first thing that comes to my mind is it may be a case of abruption, placental abruption, as there is a sudden gush of bleeding.
Do you have any evidence to support this in the clinical examination?
Yes, she has contracted
contractions are 40
from
seconds.
Ma'am, I would like to differ. Ma'am, I would like to differ.
Yes, that is what.
It looks like a case of, it could be possibly, because you're saying that there's a sudden drop in fetal heart with a fresh gush of bleeding, it could be a case of vasa previa.
Yeah. But in vasa previa, minimal amount of bleeding will be present, not a fresh gush of blood.
See, it is only a gush of fresh gush of bleeding. It is not profuse bleeding. Okay, it's fresh bleeding. That is what is mentioned. So sudden drop in fetal. Yeah, fresh. But because here, Rajalakshmi, the contractions are only 40 seconds every 3 minutes. That means there is a good relaxation in between. See, especially I have mentioned for you, contour is well maintained.
Contour is well maintained.
Correct. So if it was woody heart, tense, tender uterus, you would have been right. Right?
Okay. It may be a case of vasa previa.
Vasa previa. Now, how will you manage this case?
Immediately, I'll go for cesarean section, madam. Because fetal heart rate is dropping for fetal indication.
Yes. So
yeah,
even
in vasa previa, basically the bleeding is from the fetal origin, ma'am. It is the bleeding happens in the fetal vessels. So we have to immediately try and deliver the baby, otherwise the baby will get exsanguinated.
Yes, because you don't have to even wait for the fetal heart to drop. If at all you find, that the vessels were there, the moment the membranes rupture and you find a fresh gush of bleeding, then you suspect fetal, the fetal blood loss, that is ruptured vasa previa. And that is how you have to suspect it at the earliest. Okay, now you have very well said that you will immediately go for cesarean section. Though in this case you have, but even if you go for cesarean section, almost 60% of these babies, they'll end up into some sort of perinatal morbidity, or majority of the times it is mortality. So how would you prevent this? Can you diagnose this at the earliest? And if at all you diagnose, how and how will you go about the management? Dr. Nalini, yes. Dr. Rajalakshmi, you can continue.
Madam, clinically, Clever-Beck test or app test can be done, ma'am.
Okay. No, antenatally. This I'm saying. See.
Antenatal. Okay. First, in earlier trimesters, if there is a placenta previa, then migration of placenta is there. Then we have to suspect the vasa previa, ma'am. In this.
Yes. So how do you do that? How do you confirm that?
Ma'am, usually it is usually vasa previa diagnosis antenatally is unless we have a high index of suspicion, it is difficult to diagnose. But if we if good sonoradiologist can usually pick it up, we see a vessels coursing under the fetal head. We see vessels coursing through the membranes.
Yes.
And that is how the diagnosis is made.
Yes. So you were right in a way, Rajalakshmi. Only with that history, you could have had the differential diagnosis of abruptio placentae, rupture uterus, or rupture vasa previa. But as I have told you that because the contractions were only, adequate optimum uterine contractions and the contour was well maintained. So there was no question of rupture and even the, abruptio placentae. But as Dr. Deepa has said, that you have to have a very high index of suspicion that maybe, as you have said, the placenta was initially low-lying, now it has little migrated. So maybe the vessels divide before they enter into the membranes and, to unite into the cord. So that is how you have to have the high index of suspicion, and early recognition of the red blood will, give you the confirmation, and this is after the rupture. But then you have to do ultrasonography, and here you can actually see with color Doppler, you can see the vessels, crossing over the membranes. That is how, and if you find such cases, definitely it is a elective cesarean section. Okay. It is only the elective cesarean section that can prevent this perinatal morbidity and mortality. So antenatal diagnosis and planned cesarean section is the only effective way. You can see this. This is the specimen from this patient. This is the cord, and these are the vessels which are dividing. Here you can see the ruptured vessels. Okay, the ruptured vasa previa here.
Yes.
Okay, yeah. So we have now. Do we have Dr. Sridevi? We will go ahead with the third case. Do we have Dr. Sridevi here?
Yes, ma'am. Good evening, ma'am.
Yes, good evening, Dr. Sridevi. So we have this 32-year-old para 1 with previous cesarean section, the male child, only 1 year old. And she comes to you during 6 months of her pregnancy with history of spotting. Now she has come to you for the first time during 6 months because of the job transfer of her husband. And when you ask her further, then she gives you history of early pregnancy spotting. And that time she has undergone ultrasonography, which is suggestive of low-lying placenta. Now during 26 weeks, when you do the ultrasonography, you find that the placenta, there is placenta previa with absent the sonolucent zone. And of course, the anomaly scan is normal. This patient is under your treatment, and at 30 weeks, she starts bleeding at home, but by the time she reaches your hospital, the bleeding has stopped. Now you start investigating her again. So by the time, I would just say, by the time you send her for investigation, she collapses. So what is your diagnosis, and how would you manage this patient?
Yes, ma'am. As it was diagnosed as a placenta previa, and she's having a severe hemorrhage. Because of that, she collapsed, ma'am. First, we have to manage the mother accordingly. Airway, breathing, circulation, we have to maintain, ma'am, as mother is very important.
Yes.
And as the mother is not able to give the history, we have to take the history from the attendants and stabilize the patient, ma'am. The plan for blood transfusion, ma'am. 2 lines to be secured, oxygen inhalation, airway, breathing, circulation should be started.
Yes.
Then we have to check for the condition of the baby also, ma'am. Then
30 weeks. Okay. So what will you do? You have resuscitated the patient, but then meanwhile, what will you do?
We can
plan of management? Yeah.
Because it's a post-cesarean pregnancy, ma'am. We can plan for emergency cesarean section after stabilizing the mother, ma'am.
The patient has collapsed and she is bleeding profusely.
Ma'am, this patient, you mentioned that it's a case of previous cesarean section. Also, the scan is saying absent retroplacental space.
Yeah.
So probably it is a case of a morbidly adherent placenta, ma'am. So morbidly adherent placenta, which with patient collapsed. So we have to be very careful. There's a high chance that this patient will land up in a peripartum hysterectomy. It's more than 90% chance that she'll land up in a peripartum hysterectomy. So in addition to rapid resuscitation of the patient, we should counsel them in detail about the possibility of morbid adherence and take care for the surgery.
Yeah, but before that, you need to counsel them that she has to be taken for emergency surgery, right?
Yes, ma'am.
Because at 30 weeks, you have to talk to them about the baby also. That
Yes.
Because the patient has collapsed, we have to take her up for operative procedure. And we don't have to think about the baby, though we will try our best to save the baby. Okay?
Yes.
What will you plan? In continuation with Dr. Sridevi, now that this patient is a diagnosed case of placenta previa accreta,
Yes, ma'am.
What precautions you will take before starting the surgery? Who all do you want in your team, and what all things you want to gather?
Ma'am, we have to keep the urologist, ma'am. 6 to 10 units of blood should be kept ready, ma'am. And also 4 options will be there, ma'am, for complete placenta accreta, ma'am. First of all, just we have to deliver the baby and we can close it and we can plan surgery later, ma'am.
Yeah, we will go to the operative procedure later, but what team you want with you, along with you are the obstetrician? Do you want anybody else with you?
Yes, ma'am. Senior obstetrician should be there, ma'am. And
Yes.
also urologist should be there, ma'am.
Yes. Also, the NICU, the neonatologist.
Yes, ma'am. Neonatologist should be there, ma'am.
And of course, the team of anesthetists.
Intensive care unit
Yes,
and
yes,
intensivist and anesthetist.
And we have just discussed hello.
Yes, ma'am.
Yes, yes. So, radiologist, interventional radiologist.
Yes, ma'am. Interventional radiologist, ma'am. Yes, ma'am.
Because if you do it pre-operatively, it may reduce the blood loss. Okay. Now, in the procedure, what precautions do you want to take? What incision to plan on the uterus? How would you deliver the baby?
Ma'am, we should deliver the baby, and we should pre-oply also we should counsel the patient for peripartum hysterectomy, ma'am. That is, there is a need for hysterectomy. So 4 options are there, ma'am. Immediately after the delivery, we should never touch the placenta and we can close it, ma'am. Or we can proceed for hysterectomy. And later, or if we deliver the baby and close it, later we can plan for hysterectomy, ma'am.
How many of you agree to this? Up to delivery of the baby, I think everything is fine. That you have to take a vertical classical incision just short of the placenta. You don't have to incise the placenta, remove the baby, deliver the baby. Sometimes maybe you have to take a transpundal incision, that is called as, to spare the placenta. Okay. But absolutely no attempt at removal of the placenta. You don't try and pull the placenta. Okay.
So
how many of you want to close the uterus and go ahead? How many of you want to close the uterus and go ahead? What does the evidence say?
Ma'am, in case an interventional radiologist is there and we have facility to occlude the uterine vessels with balloon, or before that itself, if we have done a uterine, this baby is not going to
embolization. Yes.
If you do an embolization, then we can, there is a small place, if it is a totally, completely adherent placenta, leave the entire placenta there.
But if it was a completely adherent placenta, it would not have blade, right?
Yes.
So partial patchy adherence, right?
Yes. So we can leave a bit of placenta there. There's multiple studies have been done where they've left a bit of placenta there close to the sutures and waited, delayed, because we've already done embolization, waited for delayed expulsion of placenta, ma'am. As long as 6 weeks also, multiple studies have been done and they've shown that about 60 to 70% of patients, the placenta does get expelled. So it's kind of, here you preserve the patient's uterus and her fertility also in the long run. So there are studies which have demonstrated that we can do this kind of a conservative management. Or there is also Dr. Arul Kumaran has also mentioned what is called a 3P procedure, ma'am, where we plan the incision.
Triple P procedure. So what is that? What is that? That's what I want to tell you. Yeah.
So where we plan the incision slightly above wherever the placenta is located, we plan the incision above it. So that is the first P.
What are 3 Ps? You tell me.
3P is perioperative planning of incision above the placenta. Second,
placental mapping first.
Yeah,
placental mapping. Okay.
Then pelvic devascularization.
Yeah, step-wise devascularization. And
then we
patchy resection of the
patchy resection of the myometrium and closing the myometrial defect.
Okay. So do we have Dr. Sandhya Rani? I think I saw her hand raised here. Okay, so go ahead. I was asking you about leaving the placenta inside. So, do you use methotrexate? And what is the evidence?
Methotrexate has been tried, ma'am, but
that we have also tried. N number of patients previously. What are the risks in that? And what does the evidence say about it?
There is a high chance of infection, ma'am. In the infection, possibility of infection is there. Possibility of secondary postpartum hemorrhage or at a delayed, a few months later is there. So, methotrexate is generally not recommended.
By evidence also, the evidence says a strict no to methotrexate. So in fact, a strict no to closing the uterus just like that. If you have the entire placenta inside, it's either you go ahead with the elective cesarean hysterectomy, and that has to be a total hysterectomy, or if you, as you said, if you want to go for conservative surgery, the triple P procedure. And nowadays, people are going ahead with what is called as the AMOG stitch. That means they give a stitch to the cervico-ischemic area where the uterine artery divided into ascending and the descending, branches. So that place, they on both the sides they occlude, they see it, and they try and scratch out the whole placenta and try to achieve the hemostasis. Hundreds of cases have been done and people are presenting it nowadays. Even Dr. Mahesh Gupta from Gujarat, he is having n number of cases who is presenting the videos, and many people are learning from him. Okay, so that is just to share with you.
Ma'am, what is the name of that procedure, ma'am? Once again.
COMOG. MG is Mahesh Gupta. It is a internationally accepted procedure, and the name stitch is named after him. Okay, COMOG MG. Okay. So even European countries, European Association, they have accepted the stitch and the people are following it. Okay. Now that our patient has landed up into this, catastrophe, but do you think that many flaws or many problems, during the management of this patient? So what do you think that whether this condition could have been prevented? I think it's in continuation with you only. So I will change the panelists. So Dr. Rajlakshmi, I can see. Dr. Nirupama, I can see. And I can see Madam as a doctor. So I request Dr. Nalini also. Nalini, please go ahead with the discussion.
Yes, ma'am.
Yeah.
What are the risk factors for developing PA? Yes, ma'am.
What are the risk factors for this patient? How it was previous cesarean section? So are there any other risk factors you mean to say?
Multiparity, ma'am. Hello, ma'am.
Any uterine surgery for that matter. It's not only myomectomy and Rajlakshmi.
Uterine curettage, ma'am.
Yeah.
Any myomectomy surgeries, ma'am. Previous history of any myomectomy surgeries, ma'am.
Correct. So any kind of surgery for that matter, and may I tell you that even the manual removal of placenta in the previous delivery also is a risk factor. Okay. So what is the role of MRI in the diagnosis of placenta accreta spectrum?
MRI is helpful in detecting the invasion of into the myometrium, ma'am, and to know the lateral extent of the invasion, ma'am, into the myometrium cells, ma'am. And also the bladder invasion can also be known, ma'am, in a placenta accreta cases.
Yes. Okay, there are one or two people whom I would like to ask, what is the role of MRI? Is MRI superior over ultrasound for the diagnosis of placenta accreta spectrum?
It will be an adjuvant to ultrasound, ma'am, not superior, I think.
Sandhya Avagada, who is this raising hand? She wants to does she want to speak? Okay, so it is been mentioned in the literature also that a good ultrasound machine with good resolution and an expert ultrasonologist or sonologist can detect the placenta accreta spectrum very precisely. MRI is only for posterior placenta previa and morbidly obese women, I think, in this condition. And as you rightly said, that is for the placental mapping or knowing the depth of invasion before the triple P procedure. So, do we have any panelist who has not spoken as yet? We can have the discussion from them. Do we have? I think Dr. Nirupama. Nirupama, we haven't heard you. Yes. So I would like to ask you for this. So these are the theoretical aspects we have discussed. What precautions it has to be taken before the surgery that we have taken? Do we have Dr. Vidya Thobi commenting on this? Dr. Venkatramana, sir, do you want to make any comments?
Madam, ultrasound with a color Doppler with a good radiologist, madam.
Yes, yes.
He can complement that one for the.
Yes, yes. That is what we
Yes.
Yes, perfect. So, Dr. Nalini, we have this case for you. A 20-year-old Gravida with 9 months of amenorrhea. You know, she was referred to the nearby the tertiary care center at around 1 a.m. with history of early severe labor pain since afternoon. She was hospitalized in the nearby nursing home with severe pain, non-progressive labor, and these people, they have decided to take her up for cesarean section. So the sister tries to catheterize the bladder, so there is no urine. So retrospectively, they asked the history. Throughout the day, she has not passed urine. Okay, when you examine, you find that she has tachycardia. BP is 110/70. Uterine contractions are plus, very severe in intensity. No relaxation in between. The fetal heart is 120 per minute. And when you do internal examination, only 3 centimeters. Strong pains throughout the day, only 3 centimeter dilated, membranes absent, station 0, altered color blood coming out, So what is your diagnosis?
Ma'am, with history, there are very strong uterine contractions and the pain is very severe and continuous pain, ma'am. With that, I came to a conclusion which it could be an abduction, ma'am. Along with it, the pulse rate is raised. It is 110, madam, and HP is also low, ma'am.
And the investigations are
yes, ma'am. And the PT, APTT are prolonged. Maybe it landed into dick, ma'am. Fibrinogen also. Fibrinogen is less, ma'am, and fibrin degradation products are present. So it is a case of abduction with conjunctive coagulopathy, ma'am. DIC, ma'am.
Failure. So how will you manage this case?
Madam, first we have to
take her up for cesarean section urgently because she has fetal distress, or you will wait for the blood and blood products?
Ma'am, here also the mother is important than the baby, ma'am. First, I should follow the ABC rule, ma'am. Airway, breathing, and circulation, ma'am. For circulation, ma'am, I will put.
Fine, no, she's otherwise fine, my dear. At this
otherwise
point
fine. Yes, ma'am.
Stable, quite stable. Only thing is, it's not like Purana old times. No, you can say only mother and baby. The family is insisting that they want both. So how will you go?
Ma'am, I will order for a blood, ma'am. In the meanwhile, I will.
Whatever. Yeah, blood and blood components. You will arrange for it. By the time you will do aggressive resuscitation of these patients.
Yes, ma'am.
So
2 liters of
what I expect from you is everything has to be simultaneously. Okay.
Yes, ma'am. Yes, ma'am. Everything should be simultaneous, so not one after another, ma'am.
Yes.
For the cause of the dick is here is abruption, ma'am. First, we have to deliver the baby, ma'am. Not for the sake of the baby, just for the sake of the mother, ma'am, to stop the bleeding. As soon as the baby is delivered, the uterus will be contracted and the bleeding will be stopped, madam. As well as when placenta is removed, which is also a source of production of
I would like to interrupt you, Dr. Nalini.
Yes, ma'am.
So that if you have APH, in fact, I would say this is a patient who is very prone for PPH.
Yes, ma'am. Yes, ma'am. Sure.
Right? Because one thing is she has abruption. Okay.
Yes.
So you have, the cubular uterus, sometimes, the flaccid uterus. That is one. Secondly, she's got coagulation failure.
Yes, ma'am.
Okay. So it's not that the moment you deliver the baby, it will stop. No, that happens in placenta previa. Right?
Yes.
Do you all agree to me? Yes, Dr. Deepa?
Yes, ma'am. I agree.
Yeah. So, so here in this case, definitely, in fact, once you deliver the baby, you have to be more aggressive to prevent people. Okay. Okay. What else? Yeah.
I will infuse it fresh 4 units of fresh frozen plasma, madam, along with 10 units of cryoprecipitate, madam. So that clotting factors will be back, madam, and that it will be under control.
Right. So all these steps, all of you know this in detail, that you put into large bore needle, you know, IV line, you give aggressive fluid resuscitation. By the time you order blood and blood components, you arrange for your OT, the nursing staff and your anesthetist, your neonatologist, NICU, your blood bank, and, you know, intensivist and everything. And then you take care of for cesarean section, you deliver the baby, you in fact give good oxytocin, okay? Don't hesitate to give any, you know, anything less here, because this is a patient who is likely to bleed already because of coagulation failure. So you don't want her to go into atonic PPH as well. Okay. So everything has to be, you know, managed properly and effectively. So how do you give, suppose this patient requires a massive transfusion protocol. So how do you initiate that, and how do you calculate that what component is required in how much amount? Anybody can take up that. Anybody can take up that. Do we have Dr. Nirupama?
Yes, ma'am.
Yeah.
Depending amount of blood loss and the PT-INR and APTT, we decide the blood products. If the coagulation is normal, we transfuse 1:1 ratio PRBCs and FFP. But if there is coagulopathy, so we have to give more of fresh frozen plasma. And if cryoprecipitate is available, or we can go with cryoprecipitate transfusion.
Okay. So whether you would prefer here, for your fibrinogen is only 150. So whether you would prefer FFP or cryo, how?
Cryoprecipitate.
Okay. Suppose you have to give FFP, how many packs of FFP you will require?
Depending on the body weight of the patient.
Yes, that is what I'm asking you. Suppose she weighs 60 kg.
We give 1,000 ml.
Yeah, it is 20 ml per kg. Okay. So for 60 kg, it is around 1200, and the pack of FFP is 240 ml. So approximately 5 packs you need, right? To get the ratio of, and then you maintain the RBC Paxil and FFP as 3:2 initially, and then 1:1 later. Okay. What else for the fibrinogen? How, if at all you decide to give cryoprecipitate, how many packs of cryo you will require here?
2 packs. 10.
Cryoprecipitate, yes. Anybody can take up.
10 to 15 packs, ma'am.
Yes.
For every 4 packs of FFP, we usually transfuse 10 packs of cryoprecipitate.
Perfect, perfect. So that is what here we are giving 5 packs of FFP. So around 10 to 15 packs. So this proportion you have to keep into my mind, because here this patient, you have to, you know, stop her bleeding, correct her hypovolemia. Then of course, you know, her renal ischemia will be taken care. Otherwise, this patient will go into acute tubular necrosis and, you know, the irreversible renal failure or cortical necrosis. So anybody wants to add anything here? You all are welcome to add. Okay. Okay, so we go ahead with the next case. I hope you all are finding these cases interesting. And
yes, ma'am.
Yeah. Dr. Vidya Thobi here to make the comments. Do we have Dr. Vidya? No? Okay. So we go ahead with this next case now. We have this 32-year-old second gravida para 1 with previous seizure again, 36 weeks pregnancy. Suddenly she started getting, you know, dyspnea around 8 to 10 hours. She came from a neighboring district. Okay. This is case actually shared to me by my dear friend Charmila from Tamil Nadu. Okay. So this patient had gestational hypertension. And as all of you know that this in Tamil Nadu, they make echo, 2D echo compulsory for nowadays, you know, all the NCs. So this echo was suggestive of tricuspid regurg. So this patient was semi-conscious, pulse rate was 120, BP was 100/70. and SaO2 was below 90. Okay, so uterus was full term, relaxed, fetal heart was good by this time. Ultrasonography was done, it was all normal, that is what is mentioned. All routine investigations were done and apparently normal. Now this patient was, intensivist incubated her and shifted to ICU. So at 6 a.m., this patient developed epistaxis, bleeding PV, and the fetal heart was absent. Okay. Quite uneventful antenatal course. She came with history of dyspnea. They just found mild tricuspid rigors, and vitals were quite okay. But the ultrasound also done on the same day was okay. But suddenly the patient landed up into, we have to shift her to ICU, and she started bleeding. So investigation suggested coagulation failure. So what is your diagnosis here? And what
Good
was...
evening, madam.
Yeah, good evening. Please go ahead.
Madam, initially when the patient came to the hospital, she was having a pulse rate of 120 and she had a history of gestational hypertension. She was also dyspneic, ma'am. So it might be a case of concealed hemorrhage, early concealed hemorrhage, which ultrasound did not pick up earlier.
Yes, perfect. Yes.
And also uterus is full term. Actually, it is 36 weeks of pregnancy. Uterus showing full term. Usually in abruptio, we have uterus more than its actual gestational age.
Right.
That was misleading, and after intubating the patient, this abruptio induced labor caused uterine rupture.
Yeah.
Uterine rupture the next day, ma'am. This coagulation failure is also because of the concealed hemorrhage due to abruptio earlier.
Yes, because concealed hemorrhage is more, likely to go into DIC.
Yes, ma'am.
Right.
Yes, ma'am.
Yeah. So it's all of you know that if it is a revealed one, then you basically you can detect it at the earliest. Secondly, you can act at the earliest. But if it is a concealed one, then the abruptio delivery interval, you don't even notice that something is happening inside. And by the time the patient, the coagulation cascade is already initiated and it is too late. This is just, can somebody talk about this DIC score? This is, I will just simplify it that you have various parameters, the fibrinogen levels, and then you have the fibrinogen degradation products and the platelets. So these are parameters to be considered, and you score it as 0, 2, 3. And of course, if the score is more than 5, it is compatible with overt DIC. If it is if it is more than 20, if it is 5 plus, then it is overt DIC. Okay, if it is less than that, then it is just a suspicion of DIC. So that is how you calculate. And once again, we come to the same discussion, massive transfusion protocol and all this. Yeah. You can make, Dr. Venkatramana, sir, if you want to make any comments, please go ahead.
No, madam.
Okay.
Same treatment will be continued.
Yes. So naturally, immediate delivery is the best treatment, because this patient already, when this patient was referred to you in such condition, 8 to 10 hours, dyspnea and all these things, you have to investigate, and then you have to do active management. If it's a full-term pregnancy with all these problems, why not to deliver the baby and make the baby also safe? Because all of you know that once you remove the baby, even the gravid uterus, the compression and all those factors, elevation of diaphragm is relieved. So dyspnea may be relieved if it is the simple one. Otherwise, even if there is some complication, the resuscitation becomes very easy. Okay. So what they have done is, remember the patient came at 11 p.m. at night, and they are tackling this patient at 6 a.m. She developed epistaxis. Okay. So the first and foremost tip here is, do not just keep the patient on without strict monitoring. Do not just say that maybe we'll see in the morning. That is what the most important message here to be given for this case. Okay, otherwise all of you are expert enough. This patient was possibly admitted with ARDS, and of course the DIC was already in existence, which was not diagnosed initially. The placenta, later on they found that actually there was a bleeding inside, but then it did not come out, and possibly the placenta was adherent, and it was placenta percreta leading to the rupture of uterus. So delayed management of everything, delay at every step, that was the problem. So all of us feel that we have tried our best, but these are the minute things which we have to take into consideration. Every point of time you have to think that what has gone wrong, why this patient has come to us at late hours. Should we just keep her under observation and plan something that if at all she goes into active labor, then only we will see what is to be done. So this is the message, that for any obstetric any pregnant woman, when she comes to you at late hours of night, be sure that there is some problem. Okay,
Ma'am,
please.
Ma'am, because she's a post-seizure at 36 weeks, so first two possibilities, as you told, ma'am, we should think of abruption and rupture, ma'am.
Yes.
Initially, if they because abruption is a clinical diagnosis, ma'am. It's
Yes.
not based on 70% of cases. We should diagnose it on our examination only. So
Yes.
if they have made a diagnosis earlier, either as an abruption or a rupture uterus, they would have taken decision early, ma'am. We could have saved the mother, ma'am. Yes, ma'am.
Yes, save the mother and save the baby as well.
Yes,
Baby
ma'am.
the baby has died also.
Any post-cesarean pregnancy, if she presents to you with pain, we should think of whether she is in labor, scar rupture, or abruption, ma'am.
Yes.
Yes,
So
ma'am.
that is why I gave you a very simple message, that when the patient comes to you in late hours of night, don't think, why she will come all the way from home to you. Think
Yes,
that there
ma'am.
is something serious that which she is feeling from inside. Okay.
Yes, ma'am.
Yes. So
Yes, ma'am. Thank you, ma'am.
yeah, thank you so much, dear. And we go ahead with the last case now. Should we take up this case or should we stop?
We'll take, ma'am.
Yes, yeah, last one. So we have this 25-year-old gravida, second gravida with 33 weeks, otherwise uneventful pregnancy. She has history of previous abdominal surgery with severe pain in abdomen and couldn't stand upright. Okay, she has previous abdominal surgery, some abdominal surgery. She doesn't have the report. This is a very interesting case, which actually, some of our obstetrician at Nagpur, they have faced this, and that is why I'm just putting it here. So otherwise, she has, tachycardia, BP was 90/60. The uterine height was corresponding, fetal heart was 120, but tender, uterus was tender. And the cervix was closed. There was, no bleeding or abnormal discharge. So what do you think is your diagnosis? She could not stand upright. That was very classical.
Concealed abruption, madam.
That can be one reason.
One.
That can be one reason. But we want a differential diagnosis from you.
Maybe the previous abdominal surgery was a myomectomy.
With no history of previous abdomen.
Leading to rupture?
Leading to rupture.
Okay. Possibility, if you consider the DD, yes, you're right. But we still have one more differential diagnosis, which is the diagnosis. Yeah. I'm sure nobody can imagine
Maybe
this.
acute
Pancreatic spectrum, madam.
Torsion uterus.
Yeah, Nirupama, you're very right. Okay. So, see this, because everything is otherwise fine. Only thing is, she can't even stand upright and she's getting severe pain like this. Otherwise, otherwise she has no risk factor. See, everything is quite all right. And now suddenly that previous surgery has, because of the band or whatever, that may be just a coincidental finding or a history, but she has landed up into. So how will you manage this patient?
Ma'am, is it no history?
No
of
history,
abdominal
madam.
surgery or
Yes.
history of previous abdominal?
History of
Yeah, that is what I'm saying. It may be just a, the coincidental history, whether it is there or no, that has not led to this condition. But how will you manage? That is what I'm saying.
We can
the patient has landed up into this condition. So how will you manage this patient?
Other surgical and medical causes, madam, to be ruled out?
Yeah. They are ruled out. They don't find anything. Otherwise, it is quite normal.
Emergency laparotomy.
Yes.
Emergency laparotomy and delivering
But then
the
before that, you have to resuscitate this patient. She's into
Resuscitate.
hypotension. She's into, she's started developing tachycardia. Okay.
Yes, ma'am. Even fetal heart rate is less.
Yeah. So fetal distress and maternal distress also is a reason to go for surgery. That is, you are right. So hospitalize the patient, take a high risk consent, you put into IV cannulas, send investigations, do ultrasonography. Okay. So Dr. Sandhya, this was a case for you. So this ultrasound shows live fetus, transverse line, appropriate growth parameters. The fluid is normal. Placenta is anterior, no acarita, huge subchorionic and hypoechoic area. Okay. Placental tissue is thicker than normal. Okay. So that is a clot. Okay. Fetal heart now came to 90 only. So uterine arteries could not be visualized even with color Doppler. The sonologist is trying to go from this side, that side, because they should be on laterally, no? So
Yes.
they are, like this. So what is the significance of this?
Yes, ma'am. I feel this is a case of abruption, ma'am. Because of
not visualize. That is what.
That's because of the
because of the
because of tachysystole associated with abruption. Because of that tachysystole, there is absent forward flow in the uterine arteries. Probably that is a reason for absent flow in color Doppler.
Okay. So for this, emergency cesarean section was performed under general anesthesia. Approximately 100 ml coagulated blood was seen in the peritoneal cavity. It was hemoperitoneum. The amniotic fluid was surprisingly clear. Okay. Male fetus transverse line delivered by podalic extraction. The baby was live but pale, hypotonic. Large quantity of fresh clots came out from placenta. She has had large RP clots. I told you that ultrasonography is showing huge hypoechoic areas. So uterus was ischemic, floppy. So the uterus, the obstetrician has that habit of taking out, uterus. So exteriorization was done and uterus was rotated by 180 degree. Okay. So the derotation was done in a matter of few seconds. Myometrium regained the tone, and then of course there was little superficial laceration in the posterior aspect. That was a cause of hemoperitoneum. No myomas, no uterine malformation. Okay. So what was the cause for the torsion? That we are not sure. It is just a you can just say spontaneous torsion. There was no surgery, as somebody has pointed out. So that is what I'm saying. Otherwise, also a surgery will have only the bands, and it may be the cause of obstruction for the bowel. But for uterus, it led to uterine torsion. So no cause was found out, but this was a case. Why I put this case here? Because sometimes you can face this situation, which is very, very rare. So because of the torsion, it may be just some trauma to the abdomen because there was some laceration also. But we are not very sure what it can be, but there was torsion. So either it was torsion, and because of that, some extravasation of blood into the peritoneal cavity. And sometimes, I'm sure you must have seen that you deliver the uterus, and you find the uterus is so soft that even without touching, it starts, getting those clots, and it starts like injury, like, superficial injury. Even if you touch, it becomes injured superficially. So some kind of thing that has happened. But this was a little interesting case. That is why I have included it here. And I'm sorry I have taken little extra time, but I just...
1 minute, madam.
Madam,
1 minute, madam. Actually, in my 20 periods of service, I did one case of elective section where I have opened posteriorly actually. Uterus is turned.
Yeah.
There is a torsion without any complaints, madam.
Same thing. That is why I'm telling that.
Only after the delivery of the baby and everything, I identified that the uterus is turned completely. So then I derotated it Actually I opened posteriorly. That came into anteriorly. It's a complete rotation. But both mother and baby are safe without any complaints. Patient is not having any complaints.
Sir, UV fold is not identified, sir.
No, UV fold is not. Just I open it. Just open it. Then after everything delivered a baby, then only we identified that the uterus is rotated completely.
And no, and abnormal anatomy, sir. While entering into the abdominal cavity, is there any abnormal anatomy of the uterus?
No abnormality. Everything is normal, but it is completely rotated anteriorly, posteriorly.
So same thing here. Only thing is the obstetrician could make out that it is, torsion. It was a diagnosis immediately on opening the abdomen, and that is why this, with the permission of the anesthetist, informing the anesthetist properly, they, derotated the uterus and then properly they incise and deliver the baby. So things were absolutely uneventful. But then, 33 weeks without any reason, without any any medical disorder also, she landed up into retroplacental hemorrhage, fetal distress, and so many other complications. So I think we have to keep our index of suspicion very high. That is what the message is. So obstetric is very, very unpredictable. What the mind knows, the eyes see. That is why always keep your antenna very high. That is what the message is. Keep yourself, always keep predicting. And if at all you have some preventive tests or measures, try to do that. After all, keep yourself so well prepared that, not only the infrastructure, your manpower, your staff, that you have to teach them, train them in such a way that, in the case of emergency, you have to give a call to your staff and they should know, all of them, you should assign a single task that if at all an emergency, this sister will come and help me for IV fluids, this one will go and call the anesthetist and physician, maybe somebody will talk to the, blood bank, and somebody will call for the physician or intensivist. So that is how only our team also can help you by the time all your colleagues come and help you. So the message is every obstetric unit should have not only the infrastructure like SDU, but also should have a good team who is trained well with time to time evaluation, assessment, and of course, improvement in the quality of work. So that is where the role of Manyata, Foxy Manyata comes, and maybe all other organizations who are working for our, training of the staff members. So thank you so much once again. I'm very happy to have all of you as my learned panelists. Wonderful inputs from you, all the panelists, Dr. Nalini, Nirupama, Dr. Rajalakshmi, Dr. Deepali, Sandhya, and also, there are few more panelists, Sandhya and Sudharani. So all of you, I'm very happy to have you all. Madam Arun Kumari has delivered a very, very nice, excellent talk, and Dr. Sujata Dalvi also. So I thank all of you, and I just take one moment to thank my expert panelists, Dr. Vidya Tobi and Dr. Venkatramana. I humbly seek your, wholehearted support, and I request all of you to nominate me for the moment for my candidature as Foxy Vice President from West Zone, and of course, all of you to vote for me during 1st to 10th August. Thank you so much.
Thank you. Thank you, madam, for the wonderful questions, madam.
Wonderfully good session as usual. Lot of good cases.
Yes, ma'am.
Thank you, Niharika. Dr. Niharika and Dr. Sailak, they are very they are very, very helping hands for me, and they're coordinating for me from Andhra Pradesh. And all of you are so cooperative and genuine that, I'm sure that you will help and promote and vote for me, a genuine person who is a deserving candidate for Vice President. Thank you so much once again. Thank you, everyone.
Thank you. Good night, everybody.
Good night. Good night, Niharika. Good night.
Bye. See you again.
Bye-bye. Bye-bye.
Bye. Bye.